Good morning. I'd like to welcome you to the House Study Committee on Evaluating Funding for Public Health. I officially call this meeting to order, and I'll ask Representative Sharper if you will open us with a word of prayer.
All right, let us pray. Dear Heavenly Father, we just thank you, God, for this day that you've made, God. We will rejoice and be glad in it. We ask you to just continue to bless, God, this state, God. Give us the wisdom, knowledge, and understanding we need to go forth about the people's business. Lord, we thank you for the traveling mercies that you've given us, God, to even be here. And God, we just do all this in your precious name we pray. Amen.
I'd like to offer my thanks today to the Oconee Fall Line Technical College and the Porter Center for their hospitality and for hosting us today. So that you all know we are live streaming, so we have others that are viewing us. Our presentations today will be made by Dr. Chris Scoggins of the Rural Health Association, Shelley Spires, the CEO of Albany Area Primary Health Care, Dr. Keisha Collins, physician, Community Healthcare Systems, Kathleen McLeod, CEO of First Choice Primary Care. Megan Andrews is with us from the Department of Public Health. James People, the Director of Provider Services, Department of Community Health. The Department of Community Health Home Visiting Program, Christina Tice, and we'll have Holly Mobley, Southeast Health District, and Sandra Gomez-Gurin. Babies Can't Wait will be presenting for us today. Educational Alliance for Ready Students. And we appreciate everyone taking their time today to be here and share their insights on this important issue. Again, thank you for being here with us. And now if each of our committee members, I'm going to ask you to introduce yourself and tell us where you're from. We'll start with you, Representative Sharper.
Thank you. Good morning, everybody. My name is Dexter Sharper, State Representative for 177. That's Valdosta, Georgia area. I've also been an EMS paramedic for 35 years. I'm on several different committees, including public health, which is one of my greatest because that's been my life a long time. But I'm here to serve the people. I've been in the State House for 13 years, and I've enjoyed what we're doing and just happy to be here.
Good morning. I'm Angie Osteen. I am from District 169, which is Coffee, Irwin, Turner, and Tift. I'm a former nurse. I hadn't practiced nursing in several years, but I became a registered nurse in '97. And my husband and I live on our multi-generational farm, and we farm cotton, peanuts, corn. We've done a little bit of it all. This is my first, I just completed my first session, so I've got a lot to learn, and I'm always happy to learn from the people in healthcare because this is the language that I speak. Thank you.
I'm Darlene Taylor, and I represent District 173. That's in Thomasville and Grady County in Southwest Georgia. I serve as this chairman of this special committee looking at funding for public health. I also serve on the Public Health Committee, on the Special Committee on Health. I also serve on the insurance where I chair the subcommittee on health and life insurance.
Good morning. Welcome to District 155, my home. All right. Thank y'all all for being here. I do represent Lawrence County and Johnson County, serve on quite a few committees, as many of us here at the table, and chair of the Appropriations Committee. Just glad to see everybody in the big city of Dublin, and be sure and spend some money and leave some tax dollars before you leave. So just glad you're here. We've got a great facility. I'd like to thank Dr. Kraft, who is our local public health regional boss director, and he's helped get this meeting facilitated, and also Dr. Erica Harden, who's the president of OFTC, and glad they could make this facility available. And if y'all need anything, I'll try to help you. If you get a speeding ticket, I may or may not be able to help you. But thank y'all for being here, and hope you have a great day, and look forward to the meeting today.
Good morning. I'm Butch Parrish. I live in Swainsboro, in Emmanuel County, right next door. I represent Emmanuel and Troutland and Candler and a portion of Bullock. And I chair the Special Committee on Health Care. I'm a pharmacist by training, and I appreciate Chairman Hatchett allowing us to visit his district and be here with him this morning, and look forward to what our presenters are going to say as we delve into public health and what's going on there. And we all know there's a lot of changes locally and nationally, and so we're delighted to be here and look at some of this. Thank you all for your coming, and thank you for your interest.
Thank you, everyone. Now I'd like our first speaker to come forward and come to the podium, Dr. Chris Scoggins, if you'll. Thank you.
Good morning, representatives, and want to, do I need to turn this on? All right, now that I got that out of the way. So, representatives, thank you so much for the opportunity to speak today. As with pretty much everybody in the room, I wear lots of hats, and today I've got my hat on that says board member at the Georgia Rural Health Association, and we appreciate the opportunity to share with you some of the views and thoughts of our board and members across the state, all focused on the development and enhancement of rural health care for all rural Georgians. If I might, I'd also like to take a moment of personal privilege to say a personal thanks to Dr. Kraft. Years ago, almost 3 years ago, our health district director, Dr. Haynes, in the Macon district where I live, left us, and Dr. Kraft stepped in as interim director and held that role for quite some time, doing his job here and there. And I'd like to say a personal thanks to you and your staff for taking care of the health and well-being of not only those two districts, but me and my family personally. I know the impact of health care and the public health system in this state, and it's completely indispensable. And at the Georgia Rural Health Association, we want to bring these ideas and thoughts today as friends and admirers of the public health system here in Georgia, knowing that we can always do better and that the future needs us to be innovative and think about our funding and delivery of rural and urban public health in different and exciting ways. A little bit about us as an organization. The Georgia Rural Health Association, we are proud to be recognized as the oldest rural health association in the country. We were founded almost 45 years ago and have been serving the state ever since. We have a membership that runs the entire gambit across healthcare in rural communities, including members that are organizations such as clinics and hospitals, as well as individual members, not-for-profits, and a wide variety of interested entities across the state. And today we hope to present to you some of the aggregated views of those that we serve and our members, and things that we would like to see considered as you all do your work and carefully deliberate about the funding of public health going forward. So my talk today will be hopefully brief, but I want to cover three major ideas as we go forward. First, although everybody in this room is probably well acquainted with some of the challenges we face in rural healthcare, I would like to provide some context for the rest of my talk and some of the issues that we're tracking as far as challenges that we think deserve unique consideration when we're making these kinds of decisions. Secondly, I'd like to address the big issue of the funding formulary for public health and echo some of the things we heard in the first meeting. And I'd also like to highlight a couple of promising practices I think should be top of mind as we consider funding levels going forward and what programs need top attention. So first of all, challenges that we face in rural Georgia, I'll highlight just a few in more detail. But first, just the mere geography and population distribution in and of itself creates certain challenges that we need to overcome. There are certain challenges around coordination in rural communities, the ways in which we need to partner and the effort it takes to do so, and of course transportation, which has been brought up in this committee before. First of all, I think it's important to note that our state is, I believe, unique in our nation as far as the extent to which we have an urban and rural divide. We have one of the preeminent global cities in the world, and we also have counties that have as few as 1,600 people. And I highlight that because while we understand it and we know it, it does create a unique challenge when we are trying to serve all of those constituencies. Also, I think it's important to note that with the exception of the health district we are sitting in today, all of our health districts have a large metropolitan area and then predominantly rural counties outside. For example, I think one of the best examples is our Columbus Health District, where we have the second largest metropolitan area in the entire state, surrounded by some of the most rural counties in the state. So serving adequately all of those populations presents a very unique challenge that our public health professionals have been dealing with for quite some time. Additionally, the coordination that's required to deal with these multiple constituencies. We have 120 rural counties in the state of Georgia, as you well know. So that means we're dealing with 120 county governments, at least as many city governments, more than that, school systems, a myriad of EMS providers, et cetera. And this is within each district and maybe within each county. You might be dealing with not just one major municipality, but you might be dealing with 2, 3, or 4 if you're lucky. This kind of coordination presents an administrative burden that I think needs to be recognized when we're thinking about how we support these districts in their work. Also, we know that public health has districts, but our other state organizations have districts as well. And my personal pet peeve is that none of our districts in the state match up. So while my neighboring county and I might be in the same district when it comes to emergency preparedness, we're not in the same district when it comes to public health or when it comes to DBHDD services. And this creates a problem of coordination that I think is of our own doing. I don't think that it is realistic to think that we can make these districts all line up tomorrow, although I welcome the opportunity. But I do want to call out that this does present a challenge, especially for our rural communities, because these lines typically get drawn through and between our rural counties. Thinking about partners, in a given health district, if you're in a more urban area, let's take Fulton County for example, you might have a very limited number of FQHCs. We have some of our health districts are having to deal with 3, 4, maybe even 5 FQHCs, different organizations, different memorandums of understanding, different protocols, different paperwork. This is a challenge. You also layer on to that the rural health centers, hospitals, maybe having to cross district lines to get services at hospitals that are not within the district that the resident is in. This additionally provides an opportunity where there is more administrative burden within the rural context than there is within a more urbanized context. Not that urban communities don't face some of these same challenges. I simply submit to you that the nature of those challenges is substantively different for our rural communities. And last in this category, we know that transportation is the big elephant in the room. It's widely regarded by our membership and board, as well as many within the field, as the #1 barrier to access to care in our state. I don't think that's an overstatement. And I think it's important to name the fact that for many of our rural residents, the transportation system that they have within their county or municipality is functionally unavailable. And what I mean by that is scheduling or rules around mileage or rules around how many people can ride with you. For instance, a mother with 3 children might not be able to ride because she has too many guests with her. This is a problem. And I would like to call out that it is a problem that public health often tries to work their way around, but it's not necessarily the direct purview of public health to fix our transportation problems in the state of Georgia. All of this together, I'd like to submit to you as a case that says that the administrative challenges and burdens on our predominantly rural health districts are substantively different and I think also more challenging than more of our urban districts for these reasons. And that also needs to be taken into consideration, in our opinion, when considering funding. When it comes to the formulary, we heard a lot at the last meeting about this, and I think it was well established that our funding formulary really needs some work and attention. And I'd like to reiterate some of those points and also add to those. First of all, by saying that it was well articulated last time that our funding formulary, I believe Dr. Rustin said, was over 50 years old. And I don't know of very many things in the state that were the same 50 years ago as they are now.
Amen.
And I'd also like to suggest to you that the way that we have set up that formulary is incredibly crude, and we have much more advanced and nuanced ways of doing things today. I think it also does not recognize the differing needs between rural and urban communities when it comes to public health administration. And I think it also provides a certain amount of rigidity that is working in opposition to our need for innovation and responsiveness. Because as we know, the next thing that public health is going to have to focus on tomorrow, we don't know. It's going to come at us and we're not sure which direction it's coming from. Again, I won't belabor the point about the outdated nature of the formulary. It was well established last time, but again, drawing your attention to the fact that 50 years may be a bit long in the tooth, shall we say. I will not beat that horse any more than I have to. Additionally, I want to make the point that this formulary is crude. As was mentioned in the last meeting, we only take into account population and poverty when calculating how much we give to each county for the purpose of promoting their health. As someone trained in data and epidemiology, I can tell you that there are much better measures. We have measures that have already been established at the national level that we could avail ourselves of, such as the Social Vulnerability Index or Robert Wood Johnson's good work on county health rankings. The state also, and I must commend public health and our epidemiologists throughout the state, have come up with a treasure trove of data. I think we do a really good job with public health data, in my personal opinion. And we can avail ourselves of that data to try and make a more nuanced appeal for funding that fits the needs of individual communities while also providing the stability for long-term planning. And going back to differing needs, you can imagine that the needs of the Fulton County Health Department and the needs of the Lawrence County Health Department might differ a bit. We do not have the busiest international airport in the world sitting here in Lawrence County, but we do deal a lot with more agricultural public health concerns, zoonotic illness. We deal with more rabies. And I think any funding model that is developed, I would encourage you to consider those differences. And also, as part of this, I think it is key anytime when we're talking about rural health care or public health to consider that we often in rural contexts cannot leverage the economies of scale that larger places can. It just costs more to provide healthcare services in a rural context than it does in an urban context, because I can't put 20,000 people through a vaccine clinic in Lawrence County in one day. And I think that at the national level, there has been some recognition of that through the Critical Access Hospital program, through certain programs that our FQHCs use, through the Rural Health Center programs, that it does cost more for these people to provide care to rural environments. I think that I would encourage you to take that into consideration and think about that, because the fixed cost of providing public health within a small county don't scale directly with population. And lastly, in this category, I wanted to talk a little bit about rigidity. I think public health is unique in, well, I wouldn't say unique, but I think that one thing that is really critical about providing good public health services is flexibility. On March 9th of 2020, we didn't know what was going to happen 2 days later, and we would be in a global pandemic. We might have had some inkling, but we didn't know what was going to happen. And that's the nature of public health work. You don't know when the next rabies outbreak is going to happen. You don't know when the next septic spill is going to happen. You're not going to know when you're going to get run over with a bunch of salmonella outbreaks. And having the ability to adapt on the fly to meet the needs of the citizens of the district and the county is important, and that requires a certain amount of flexibility in funding. Future needs are hard to predict. The healthcare world, and I needn't belabor this point, it's progressing at an exponential rate. We see year over year an acceleration in the change within healthcare, and we've got to be able to adapt to that. Part of that also, and I'll comment on a topic that was brought up at the last committee meeting, the idea of pay scales for many of our providers. We have shortages everywhere. It affects us in rural communities more acutely. And also, our providers within rural communities who are paying market rate are having trouble staffing. And the problem of maintaining and recruiting a workforce to do this critical public health work is not going to begin to get better until we can pay market rate for our professionals. And I know that, unfortunately, Chairman Hatchett, I know, does not have a money tree in his backyard. Otherwise, I'd be over there today. But I do encourage you to really consider this, and I know the state has made huge strides in teacher pay rates and other professionals. I would really love to see the state put some thought and effort into trying to figure out a way to do the same with our public health workforce. And lastly here, innovation requires flexible funding. We need to be able to invest quickly in promising ideas, and we need to have funding mechanisms to do that. So in summary, for our funding formulary, we'd like to see a new formulary that recognizes a fuller picture of health and health needs. And that comes back to how we calculate those funds. We want it to also acknowledge that rural health departments do not enjoy those economies of scale. And we also want to see that that formulary provides a certain amount of flexibility needed for good and necessary innovation within our public health system. And lastly, you guys are going to hear from some really great people. I really was excited to see this agenda today, but I want to call out a few promising practices that we at the Georgia Rural Health Association would love to definitely see continued, but also see enhanced and refined. First and foremost, the maternal and infant home visiting program, I think, is critical in the communities that it serves. And they are dealing with and really making headway in two critical issues in our state, the issue of maternal and child health, and also in the issue of transportation. It's a really simple idea. If mom can't come to the clinic, why don't we come to mom? And it works brilliantly. We'd love to see more coordination with other forces because we can't duplicate services in rural areas, and there are some maternal health services scattered across our rural communities, and we'd love to see a greater integration of those services, but this is certainly a program that we are big fans of. Again, I personally think that we have a great data system in the state of Georgia, a great data collection system when it comes to public health. Our state OASIS, our publicly facing OASIS system that makes data available to the general public is, as a data nerd, just makes me so happy every time I can go to it. But I think that this is really a bright spot and something that's an asset for our state that we need to continue to invest in. We heard at the last meeting also about the exciting news about a comprehensive EMR that's being implemented. We at the Rural Health Association encourage that. Anything that improves interoperability across rural communities, we are for. I would like to see that system as interoperable as possible, recognizing that between all of our FQHCs and rural health clinics and hospitals, everybody uses different stuff. It's a challenge. When EMR came about, we were promised that it was going to fix all of our problems about interoperability, and that hasn't really materialized. But I would really love to see this system rolled out in such a way that it serves not only our public health partners, but helps us integrate better with public health in our clinics. And the last thing I would like to mention is a topic that was brought up last time about having a common set of services between each health department. And we would love to see a baseline level of services in every county. Our one word of caution, or at least suggestion, would be to make sure that we are availing ourselves of the community health needs assessments that our public health departments are doing to make sure that we're not duplicating services. Because especially in rural communities, we need to make sure that if our FQHC partners, who you'll hear from later, have a funding stream for something, maybe we can defer to them for that or work with them to develop that service more and focus instead our public health dollars and efforts on services that are not available. Because some of these services do exist within our communities, and we just want to see that the most efficient implementation is there and all the stakeholders are at the table as those discussions are being had. And with that, these are our humble submissions to the committee of the ideas that our association and board have brought forward, having listened to a lot of stakeholders across the state and across our membership. And we, as always at the Georgia Rural Health Association, are here to be of service to all rural Georgians, to our public health partners who we value so greatly, and of course to the committee and the state. So with that, I'd love to answer questions if you have them, and I, again, thank you for your time, Chairwoman.
Thank you for the great information you have shared with us today. I do have a question. Chairman Hatchett?
Thank you, Chair Taylor. Dr. Scoggins, I knew you, and you knew me when, well, I'm still Matt, and you were Chris, so, and you got my number, so you know how to call me, so please do. You mentioned a lot about funding, and of course that, I look at myself when you mention funding. How have y'all reached out to the public health, the Department of Public Health, to discuss a new formulary, to discuss how it might work? Have y'all done that?
We have not. We bring this suggestion to the committee as a thought around ideas that we see as being beneficial to our rural communities. We would welcome that conversation with our public health partners. We are just a membership organization. We don't really have a say in that decision, but we just wanted to provide some information around the ideas that we thought could be beneficial.
Well, I would argue that you do have a say. You're a citizen, and you can have input in any decision like that. So I would love, maybe if Megan Andrews wants to address some of that when she speaks, but I would love, I've tried to go back and remember if I've had any formal discussion about changing the funding formula. Of course, we have discussions about increasing everything. Cut others, don't cut mine. But I think they would probably welcome a discussion anyway. So I hope that can proceed. How many members do you have in your organization?
I actually asked our executive director this yesterday, anticipating that question. We have over 150 organization members across the state.
Okay. So I just would hope y'all open up those discussions and I entertain looking at anything like that to see what kind of recommendations. I know transportation is an issue. Transportation is an issue not just in public health and a lot of different of our many of our different agencies. So, but I look forward to seeing any recommendations brought forward.
Thank you.
I will concur with that. I think that's a discussion that needs to be had. Something that's 50 years old doesn't fit in today's world. So I think that's something we are gaining a lot more insight on. Any other questions? Okay. Representative Sharper?
Thank you. Thank you for being here. You mentioned that the data collection is great. I don't know if this is going to be more of a question for you or someone at the health department, but getting all that data in, are you seeing you guys use that data in a way to really affect a lot of change? You know, a lot of places they collect data, but do nothing with it. So can you address that, please?
I won't speak for the health department directly. I will say that from an understanding and planning perspective, the data, the epidemiological data that the state collects at the county level and then funnels up to the state is very high quality and can be used readily for determining issues, outbreaks, et cetera. I know within our health departments, they utilize that data for many parts of their operation. I won't speak specifically to that because I don't work within their scenario, but it is my impression and my understanding that they do use that data actively and daily.
Okay. Well, we'll hopefully follow up with someone that can, give us some ideas of how this information is being used. Mm-hmm. So, thank you.
Yes.
Are there any other questions? I don't see any, and we do appreciate what you've brought forth. I think it's some good information, and each of us on this committee do represent some rural areas, so it's very important that you brought this data. Thank you.
Thank you, representatives.
Our next speaker is going to be several people. They're from the FQHCs, and we'll start, if you will, please, with Shelley Spires. If you'll come to the podium.
Thank you, Chairwoman Taylor and committee members. We appreciate the invitation to speak here today as it relates to our federally qualified health centers. Georgia Primary Care Association is actually our association that helps bridge a lot of our gaps with our individual FQHCs throughout the state with other partners so that we can continue to make a difference in the communities that we serve. Georgia Primary Care Association represents about 36 FQHCs. Just for historical purposes, lay a foundation, we do primary care, preventive care, we do mental health, we do school-based health centers, dental, outreach, enrollment. We do a gamut of services to our patients in our communities. And so we're very excited to be here today to share that. Also on a more individual level, to share what we're doing in our communities, but also give you an idea about the partnerships that we have with public health. So the group here today will actually be representing FQHCs from Sandersville and Macon, and then I'm with Albany Area Primary Health Care in Albany, Georgia. I'm Shelley Spires. I'm the CEO. I've been there for 25 years. This is my 10 years as CEO, so I guess I hit a milestone. And before that, I was Human Resources. Prior to that, I come from a critical access hospital that actually ended up closing due to sustainability and funding. So I have certainly a heart and a passion throughout my career for rural health and the things that we do in our little small communities. As we talk about the gaps, as we look at the healthcare in our areas, and of course I'm Albany, Georgia, we have 14 counties that we serve. We have 57,000 established patients, over 217,000 visits, with a variety of services around primary care, internal medicine, family medicine, pediatrics, OBGYN, dental, school-based health centers, behavioral health, podiatry, optometry, ophthalmology. So we do a variety of services, and kind of my vision from where we stand was to be able to create a pipeline for our patients to be able to access care in whatever area that they needed, just like you and I have those privileges. And so really just trying to build that network for our patients in our community. One of the things we were asked to talk about today was just really around how do we partner with our public health? What is the relationship like there? And so just really give some feedback. We actually have a really good relationship with our Department of Public Health. We kind of try to figure out who's got the strengths in what area and the weaknesses, and then we kind of build on them if at all possible. One way we've done that is through the breast cancer and cervical cancer program in the state of Georgia. We exceeded our quota for last year at over 582 visits. around breast cancer and cervical cancer programs. And so we were able to bring everybody to a room, and it happened probably 5+ years ago. We brought everybody in a room and we were like, okay, what can we do? The hospital agreed to be a partner in that. Public health knew we had the staffing that could assist with that. So we were able to actually take this program on and been very successful with it since then. And so we take real pride in that. But the idea is we had a common interest for our communities, and we were able to make it happen. So we were very excited about that program, and we continue it today. We also had an opportunity to do a centering program. And so kind of the same thing, we met with the public health department, we talked about some of the deficiencies or staffing issues that they had. Where could we play a role? It started out that we would just sign off on the maternal health charts and deliver the babies at a certain period in the pregnancy. I think it might have been 36 weeks, 39 weeks. Dr. Callens can probably talk more to it because she actually was with me during that time. That they would sign off on the charts and actually deliver the babies at our hospital. And so that was a nice partnership there to be able to continue that prenatal care. Fast forward a couple of years, I believe we were able to, at that point, assist the health department in taking on centering. So we just thought, let's just bring it in and be able to, so we're signing off on the charts, our physicians are delivering the babies. What if we took that centering on? Not long after that, COVID hit, so it's kind of fizzled, but we are revisiting that program again. Vaccines. So we've talked a lot about COVID, and this is, to me, where it really shined. And that FQHCs, if you're not sure or not familiar, we're the best kept secret. And so we try to make sure everybody understands it's not intentional. We want people to know about our secret. And one of the things we realized during the pandemic is we were not a part of the table, that we were not at the moment, at the heat of it, brought to the table. We wedged ourselves in, and I think once we did that, we were like, oh, we were accepted as a part, we're a part of this community resolution, if you will. This is how we're going to address or attack this pandemic. And so with that, the relationships became stronger. And we had such a wonderful relationship, in particular with the health department, because they could get vaccines. And we couldn't. And so vaccines surfaced December, I think, November, December, and so we're going into January, and we're closed on Martin Luther King Day. And so we decided as an organization, let's open up, let's do vaccines. We can do about 1,000. We think we can get 1,000 vaccines in people's arms on this day, but we didn't have 1,000 vaccines. So reached out to Dr. Charles Ruiz and had a conversation, and we were able to borrow from Peter to pay Paul, if you will, but we were able to bring those vaccines in. We didn't quite hit 1,000, we hit about 800, but not too bad in a given day to help eradicate the pandemic. And so really playing a part and coming and joining forces, we can move mountains, and so we were very excited about that. Some other things that we do with our health department is infectious disease, HIV/AIDS. So we could do the primary care side, they can do the other pieces, and so we were able to jump in and help satisfy that piece of primary care for HIV/AIDS population. And so we do that in Thomasville, actually, and we do it twice a month. Some of the other things now that we do to actually stay ingrained and involved is we have 2 physicians who serve on local health department boards. And so we're able to be at that piece of the table and really have conversations about, you know, what's happening in our communities and what can we do together to make some changes. One of the things that we pride ourselves on is that we actually have data. I think Representative Sharper, you were talking to that. So we, as FQHCs, of course, are held to some standards and regulations by the feds. So we have to keep the data, which is a great thing. And EMR has made it 10 times better than 25 years ago when we were auditing paper charts. And with that analytics, what we can do is actually create PDSA cycles and look at Plan, Do, Study Acts and really come to some conclusions about how do we address this issue. And we can actually put it into play in one of the clinics and see how it does, tweak it, and then spread it across organizations. And so that's one of the things that, you know, we've been able to do also with the health department is really looking at where are our deficiencies, where are our issues? Because if I'm seeing them and 52,000 established patients, the health department is seeing them too. I mean, so even though it may not be the same patient, I would bet the analytics kind of mirrors one another. And so having some of those conversations with our health department, being at the table with them and being able to strategize on how do we, as Dr. Scoggin said, how do we build those forces so that we're not duplicating, but we're actually strengthening the ability to move that mountain. And so we're very excited about the partnership that we have had throughout the years. And, you know, we talk a little bit about too, we were sharing a conversation earlier about sometimes it's, the duplication of services is one thing, but sometimes not understanding what's happening at the FQHC level and not what's happening at the public health level, and having those conversations so that we're clear on who's doing what, so we're not duplicating or spending money twice in two places. How do we build that? And, you know, one thing that we, you know, I was like, if we could just be at the table so we could explain, these are all the things we're doing. These are all the projects we have going on. Because a lot of times we are also participating in academia pilots also. And so how do we bring those institutions to the table? How do we use some of the funds they have and really just figure out how we build it? And I think with that, we would see as we create these PDSA cycles as a cohort, that we would see some of the outcomes be moved in a positive manner. All right, and with that, I will actually get ready to pass it on to my next colleague, Ms. Catherine McLeod, to speak to her FQHC in Macon, Georgia. Thank you all.
Thank you, Chair Taylor and members of the committee. Appreciate the chance to be here today. Again, I'm Catherine McLeod. I'm with First Choice Primary Care. We're the FQHC in Macon. We also serve Warner Robins. I'm sure you all have learned every FQHC is different. We're in an urban area, but we serve a lot of patients. About 1,000 of our 12,000 patients actually live in the surrounding rural counties. So I know people don't think of Macon as part of the rural conversation, but it does matter to us because it matters to our patients, particularly when you talk about transportation and some of those challenges. We have several sites in Macon. They are all different. We have one service site that's in a homeless day center. We go twice a week with a nurse practitioner. We send a behavioral health counselor, a case manager to serve the homeless. We have another site that's in the heart of downtown Macon, South Macon. But our most interesting site in relation to today's topic is 10 years ago, we received funding to open up a new site, and we opened up an office inside the Macon-Bibb County Health Department. That came about, as with so many things, because of personal relationships that develop. That's the way everything gets done, really. But for a period of time, the county administrator of the health department and the CEO of our community service board, River Edge, and I would eat lunch together once a quarter and talk about what's going on in your world. As understanding funding streams for community service boards and for public health and for FQHCs, we were all trying to serve the same people, but we all had different regulations and mandates and limitations. So we would just sit and talk about how we could help each other and address some of those gaps. So there was a suite of exam rooms inside the health department that they were no longer using. So we leased that space from them, really just cost sharing, paying utilities, that kind of thing. Because the community service board, River Edge, was in the other part of the building. We share a lot of patients with River Edge. It made it a lot easier for those folks to get to us. And then if there was an issue that related to a health department service, we could just send them across the hall. And it had its challenges, and it was, whether we were going to give vaccines to our patients or send them across the hall to get a vaccine, we had to work through those issues. But it ended up being a great partnership. It made better use of the health department space, and it certainly made navigating for some of those patients a lot easier. Since that time, the health department has moved into a new building, but we're still there with River Edge, and until we're both in the process of moving out of that building. But that was a pretty unique partnership that I think was good for both the health department and for First Choice. We have a good relationship at the district level, and I was delighted to learn that we do now have a permanent health director. I've not met Dr. Cook personally, but look forward to, we've exchanged email greetings and look forward to getting to know him. I have to tell you that there's a staff person in the district level that I've worked with for years on lots of things. I called her and I said, I'm talking about public health. I need to talk to somebody in public health. So just to check in with what's happening in public health. And that was when I learned we do finally have a permanent health director. We also, as with Albany area, one of our primary collaborations locally is with the Hope Center, which is the Ryan White HIV clinic in Macon. And we refer patients there. They come back to us for primary care. We work real closely. We're on their advisory committee and have shared patients and information with them for many years. Also, we really depend on public health, the epidemiology, the Emergency Preparedness Coalition. We've been real active in that, and that certainly was helpful when the pandemic befell us. Being able to call those people in public health and in the regional coordinating hospital, they knew who we were, and they understood what we did and what we needed. That was a huge help, being part of that. Another issue in Warner Robins, our office in Warner Robins is near the Air Force Base. It's in a part of Warner Robins that the city is trying to redevelop, but the health department is further away from that part of town. So at one point, the health department asked us if they could use some of our space. This is sort of the flipping what happened in Macon. We invited them to come use a couple of our exam rooms a few afternoons a week for their family planning program, because a lot of the people they were trying to reach lived in the part of town where we were located. And these were people who could not get out to Highway 96 where the health department is. They have a great facility, but it wasn't, if people couldn't get to them, it didn't do them any good, so we offered them space. That's just an example of, they were providing a service that we were not offering, and we had the space that was more accessible to their target population, so we were happy to do that. Breast and cervical cancer program, as Shelley mentioned, over the years, various funding sources have been available to us, either writing grants to the Susan G. Komen Foundation. Now our United Way raises some funding, but every now and then that funding would run out, and so we would sit down with the health department staff running the breast and cervical cancer program, and we could send people to them if we ran out of money for mammograms, and we would just kind of figure out how to make use of the funds that were there. We are also currently trying to work on a way with Macon Health Department that their dentists can help us with a dental hygiene program. We have 2 school-based health centers. We'll soon open a third, thanks to the grants through the Georgia Department of Education. We're excited about that and want to have a dental hygienist in those sites. And so we've been talking with Dr. Smith in Macon-Bibb County about how potentially to coordinate with his dentist. And that's, we hope we can work that, have that as another example of how we're able to expand the reach of services by collaborating. There are truly things that only public health can do, though. There are things that are just beyond what a health center is capable of doing. Epidemiology, disease surveillance, some of those things that we really rely on. And the OASIS data, Representative Sharper, you asked about that. We use the OASIS data looking when we're doing needs assessments. We rely on access to that data to make sure we know where the greatest need is, what health issues are the biggest problems based on that data. I know every health department is different, just like every health center is different, but some of the services that are offered I'm really just familiar with Macon and Houston County, but there is some overlap. I wouldn't say it's competition because there's more than enough need to go around. If you're talking about hypertension and diabetes, I would love it if it was competition, meaning there was a lack of patients, but that's not the case. But my observation from the outside is that health departments, it seems that so much of the funding is for this disease and this disease and this issue that it's hard to serve the whole patient. I know in Macon-Bibb, they're providing care for diabetes, but if someone gets to the point that they need insulin, an injectable, they can't provide that service. They have to refer them. So they're treating that disease, and that's great that people are able to get access to that, but it's limited, and I would guess that would be frustrating to that provider, that there's only so much they can do. They can't continue to care for that patient, as well as meeting needs for all the other things and that individual person would do. Do they need a colonoscopy? Do they, all the other services that they might need referrals for? I feel like we're fortunate with our relationships in Macon-Bibb and in Houston County. Both of those are very different communities and different health departments. They've done a great job responding to the needs in those communities. And we're always looking for ways we can make better use of their resources and ours, because there are huge needs yet to be met. But thank you. I'll ask Dr. Callens to come, and then when we're all done, we'll answer questions together, if that's okay.
Good morning, everyone. Good morning, Chairwoman Taylor, and to the committee. Thank you so much for having us today. My 2 colleagues have done a great job of presenting an overview of some of our federally qualified health centers And there are lots of familiar faces in this room, so hi to all of my friends. And if you're not my friend yet, I can be your friend. So my name is Dr. Keisha Callens. I'm actually an OBGYN with Community Healthcare Systems. I have been there officially, actually this month will be 8 years. And prior to my 8 years with Community Healthcare Systems, I was with Albany Area Primary Healthcare. And I'm an OBGYN by training, trained here in Georgia, but I had the good fortune of actually getting my public health degree before I went to medical school. So I tell people all the time that I got ruined very early. And so public health is a great connection point to clinical medicine, and I have a couple of thoughts that I want to share with you. So when we're done a little bit later on, Ms. Becky will provide a folder for you, which will have some statistics and information about each of our clinics. And as was mentioned before, you know, if you've seen one FQHC, you've seen one FQHC. So we also are in several counties, 14 counties. We have 19 locations and offer a variety of services from primary care to podiatry, dental. We have nutritionists, we have social services. We offer the gamut. But one thing that's unique about us is, whereas with Albany Area Primary Healthcare, they have a dedicated women's health center that has several OBGYNs on staff and nurse practitioners. For Community Healthcare Systems, we actually have myself as an OBGYN, and we have one women's health nurse practitioner. So the dynamic of how we interact differs across the different FQHCs. Also, before I go any further, I wanted to mention I'm speaking on behalf of Carla Belcher, our CEO. You had 2 CEOs, and then you just have me. And so I did want to acknowledge Carla Belcher. She is phenomenal, and a lot of people in here are probably familiar or aware that we have the Georgia Rural Health Association, and so we're all kind of heading there next. But just wanted to acknowledge her as well. So I want to tell you a quick story, and I'm going to be brief. I know I'm on the clock. But there's something unique about partnership. And it's probably too early for me to talk about pudding, but my new term is the proof is in the partnership. What does that mean for how public health intersects with federally qualified health centers? And as Shelley mentioned, we technically are the backbone and the infrastructure for healthcare, and that happens because a lot of the patients we see are uninsured, which is a large group, but then we also have patients who have federal insurance, and then we have also private payers. But what happens is a lot of the patients who are uninsured are kind of having a hard time accessing care. And because of our relationship with the health department, we can help to kind of fill in the gaps in that circle of care. The story I'm going to share with you is I had a patient who came to me from Augusta. I work primarily in Twiggs County. Twiggs, if you're familiar, is this geographic center of the state. I'm still the main physician that's there for the last 8 years. We do have a community healthcare clinic there. We have a nurse practitioner that's there. We have a school-based clinic. But as a physician, I'm usually there at least 3 days a week. So I had a patient who came to me from Augusta, uninsured. She had a GYN issue and just happened to be friends with the nurse practitioner who was in Washington County. And she said, if you go see Dr. Callens, she'll probably can help you. And I was able to do that. But what concerned me is this is a patient who drove more than 2 hours. She had an issue that could be addressed. But because there was not a connection with the health department there and the private practitioner, that care did not happen. And when I saw her, the advancement of her issue, she had a condyloma that was pretty impressive. It's a lesion in the vulvar area. That could have been addressed a long time ago. And so that's an idea of why, or an example of how that connection is important. Currently, I have patients that are across central Georgia. I have the cell phone number from a lot of the nurse practitioners in different clinics, and so it's not uncommon for me to get a phone call. I got a patient last week from Miss Becky who's in Telfair County. Joy's in Houston County. If I start calling too many names, people are going to get offended, but my point is that connection is extremely important for us to be able to offer care. And what does that look like? So in the GYN sense, for example, a lot of the communities where there's a health department, if there's an FQHC, if there's an abnormal pap smear, I can do their colposcopy or their follow-up pap smear. And that is something that requires a special microscope that we have in our office. And so, for example, if I'm in Twiggs and the patient lives in Twiggs, before I was able to offer that service, they were either driving to Dublin or Milledgeville or Macon or Houston just to get a procedure. That is fairly easy to do. But because we have that capacity in our clinic, we can take care of that. So that's just one example. The second example, vaccines, was mentioned before. The RSV vaccine is something that has been promoted for pregnant women. A lot of times we're not able to necessarily stock that in terms of depending on the hospital, the clinic. But because the health departments have that, there can be a relationship where I can counsel my pregnant patient on what she needs, and then she can go to the health department to receive that vaccine as well. Same thing happens with the HPV vaccine or Gardasil, being able to diagnose an issue, work in that preventive care, and then having that direct relationship is extremely important. When it comes to long-acting reversible contraception, for example, the Nexplanon, if you all are familiar, it's a little rod that we place in the arm to help with birth control. There are some private practitioners that don't offer it, and there's some hospitals who can't offer it. So what do? We refer to the health department. So again, just because one person does not have something does not mean the patient does not have access to it. How does that partnership, if we can strengthen it, as you mentioned, really help to make sure that patients have access to what they need? And so I think there's an opportunity for us to really strengthen that infrastructure. The last thing that I'll mention is, and a lot of this is just coming from the clinician perspective, is training. So right now I have a nurse practitioner who is in Houston County, and I'm doing some of her observerships for her to learn how to do the colposcopy procedure. So again, she's able to come to me, see how I practice. I can work on giving her some additional support for GYN procedures. And so just those 4 examples alone shows that we cannot work in silos if we intend to really make an impact in the community. And I think we have a really good opportunity to make sure that we are making those connections happen. And so from a clinician standpoint, it has to be very intentional. And so I have made it my business to make sure that I can connect. Also, not all of our health departments have a nurse practitioner on site all the time. So again, what does that mean for how we coordinate care to make sure that we have the appropriate coverage? So I think there's some opportunities there for how we can really tighten that safety net for how we address the needs of the patients. And then also too, how do we fill those gaps in care? And so the FQHCs do have a very important contribution to make, but that's not in isolation of the health department. And we're definitely not competing, as was mentioned before. It's cooperation is the new term. Cooperation, forgive me. So I just really wanted to just share from a clinician perspective how I see my interaction with the health department. And, it's funny, I'll give you one last story that's kind of a joke. During the pandemic, we had an issue with access, and, it's not uncommon for us to run out of condoms. And so the health department can call me and say, hey, do you have some so we can give them out? Or I can call them and say, hey, I'm out, my shipment's not coming in, can we get some for the patients? So just being able to make that simple phone call makes a really big difference for the patients. And so if we're all committed to the same thing, which is improving access for patients, improving their health, improving their well-being, then we cannot not communicate in a way that is constructive, intentional, to really improve things for our patients. And so I just want to encourage you to think about what ways we can strengthen those relationships, that infrastructure, whether or not it be direct service, coordination of care, or in training. I think there are lots of opportunities. And to take that one step further, if I'm the only OBGYN with community healthcare systems and we have 14 counties, that sounds a little crazy. So what kind of appropriations can we make to make sure that all of our FQHC networks will have that women's health contribution where appropriate? And I think Becky can speak a little bit more to that. And that's something that we still need to work on. And again, I'm biased, I'm OBGYN, so I'm thinking about it from that standpoint. But we do a lot of focus on maternal health, which is appropriate. But I just want to take one last moment to say, preconception care is exceptionally important. FQHCs can be that link. And so if the health department becomes that entry, then that link to us is really important. But then also, once you are done with childbearing, there's menopause. There are lots of things that come up. And I get a lot of referrals from the health department for patients who, they can do their pap smear, but if they're, sweating their hair out and they're melting when they're outside in the heat, then they can make that referral to us. And so I think we have a lot of opportunity to really expand the access to care that our patients deserve. And we can all agree that we want our family to be well taken care of. Nobody can disagree with that. Our healthcare should not be determined by our zip code. And I think the relationship between the health departments and our FQHCs is an opportunity that we have, an infrastructure that already exists that we can amplify to improve outcomes for our patients. Thank you.
Thank you. Again, that's a lot of great information. I think we may have a couple questions if y'all want to come up. Actually, I have a couple. In Macon, will you be moving into their new health facility?
No, we will not. They moved to a building that is right in downtown, very close to our main office. We may end up with a site inside a River Edge's new building, just because primary care for folks with behavioral health issues, but not the health department.
Okay. And another question I have is, are the FQHCs, do you have access to different and more grants and funds than our health department? Do you know? That's something I want to look into.
Yeah, I've never compared the two, actually, but I do, I would have to defer. I really, that's something I'd look into because I'd have to compare the two.
Okay.
I don't think we have enough as
You
FQHC.
never know.
But I'm pretty biased, but yes, we can definitely compare the two and get that back to you, Chairman Taylor.
And I'm familiar with my FQHC. Do most of y'all have some kind of a navigator that helps people that are uninsured find coverage? So most of, and again, we'll find out if the health department does that too. I don't know if they refer them to you or if they have their own.
Yes,
We do.
we all have staff that are that help people with access to applying for Medicaid or the marketplace insurance.
Okay.
But one thing we did last year with the health department, we have access through an agreement through the Primary Care Association to the Gateway system. During the Medicaid unwinding process last year, the health department did an event, and our staff went and spent, they scheduled the event for about 3 hours. It lasted about 9 hours because there were so many people there. But we had access to Gateway, and the health department staff did not, which
Need to look into that.
surprised me because we frequently use that to help patients with Medicaid, SNAP benefits, child care assistance. Those are the big ones, but
Okay.
that's
Thank you.
that's a service we do offer.
Thank you. Are there other questions? Oh, Representative Sharper?
Thank you so much. I'm both-brained, so y'all know. They call it both-brain. My brain goes right and left all the time, okay? So some medical people understand that. All right, I want everybody just to think of something. We see that for 50 years, a lot of things that weren't changed, with the health department, different things. But if you can imagine with the data that we can use, and we can almost call it an audit of the health department, to look at some of the partnerships and collaborations that we see. I know that every health department is not going to be the same, but we're going to have the general things that all the health departments need and also the services that they provide. But I think either we need to get with Dr. Toomey or get with someone, and let's look at an audit of all of our health departments where we are sharing space with others, what's working, what's not working, and look at our health departments more like a transportation. You don't build infrastructure for just what we're doing next week and what's going to happen a year from now. We got to look at 25, 50 years of what we're doing in our health departments. So a lot of times we see health departments build, then they run out of space, and they have a building here, have an administration over here, services over here, services over here. But if we think forward and look at the dental opportunities, the other nurse practitioners, the OB, look at all these things going forward so that one way or the other, if we have the space, even if we have to share space until we can provide that service ourselves as a health department, or having that space available where there's dentistry, minor things that we can do, I just feel we need to look more into what we're doing, who we're sharing space with, the pros and the cons of the situation, and move forward and see if there's any funding that we can get for you guys, or you guys may have funding, federal grants, other things that can actually help relieve some of the state budget money. But I think overall, these are things we have to look at the process of auditing and this data that we have and use it for the future so we can be in better shape and we're not just looking ununiform across the state. But I just want to put that out there, let everybody think that in your mind, how we can figure out a way to have a meeting on specifically addressing that.
Thank you. Chairman Hatchett, you have a question?
Thank you. I just want to thank each of you for taking the time to come here today and tell us your stories. Dr. Callens, you're a superstar. I just wish you were a superstar for men's health and you could take care of me. But anyway, I just, you know, each of you touched on on you know, in a roundabout way, your co-housing, the success you've had there. You know, it takes out the transportation issue, it takes out duplication issue, and I think you've addressed a huge problem with medical care in general, even at the big successful hospitals and hospital systems. You know, you got to go here for this, and you got to go here for that, and here for that, and here for that, and you got to schedule them all at different times. So I mean, it's a system that's not efficient, and I think there's a lot of things that we could probably do to look at the efficiency and break down these different silos, even that we have within the agencies that handle health care for our state. You know, the communication has got to be open, and there's got to be, in the long run, some savings. If not savings, it's improving the health care and improving, which is each of these agencies' goals, improving the health care of our citizens. So hopefully we can work toward, y'all touched on some things that have definitely piqued my interest and the gentleman to my right's interest. So thank you.
Chairman Parrish?
Yes, ma'am. Well, first of all, thank you all for what you have shared with us this morning. And I think we're at the point that we may be able to look at what can we do to make sure the patient receives the best services we can. And is it time for us to look at certain things the public health department does, and they do very well, and they should do. And there's certain things FQHCs do, and they do well. And sometimes duplicating those services, it doesn't really make a lot of sense. So if we sort of decide cohabitation in some of the departments, the transportation issue that you mentioned about if a FQHC is in that county, they can be serviced there as opposed to having to travel an hour or two to do that sort of thing. And I think that, as Chairman Hatchett and others have pointed out, it's really time for us to take another look after those 50 years of funding formulas and everything else. Do we need to make a really seismic change in who's doing what? Whatever can do it the best, most efficient and effective, that's what we ought to be doing. And if not, we ought to move that out into something else. And thank you all for sharing that with us. And I'm sure everybody has some different ideas about what we ought to be doing. But I think that's something we really need to take a strong look at. Thank you.
Thank you, Mr. Chairman. Representative Osteen?
Yes, ma'am. Just in listening to y'all and listening to Representative Sharper and Chairman Hatchett and Chairman Parrish and Chairman Taylor, I was just thinking, you know how Mayo Clinic works? Anybody ever been to Mayo Clinic? You know, you can go to Mayo Clinic for your heart, but then they need you to go for ortho for this, and they need to go here for that and here for that, and it's all under the same house, right? So I think those are great things. But, you know, sometimes I wonder if lack of access might also be related to just lack of knowledge of what's in your community. Like, I didn't know that there was one in my community and one in Irwin and one in Turner. I didn't know, and I'm a nurse, and I feel like I have my fingers in a lot of things in my community, but sometimes it's just lack of awareness of what's there and where to go. So you said, I think there's some opportunities for for working together. I think that we're past that point of, we need to identify, what do you think we can do? Like, I love seeing in these community events where the health department's there, the hospital's there, all these different entities are there, like, where Holly Mobley and I live, we're about to have a big buck contest. Thousands of people come. It'd be great to have little pop-up tents. It's at night, it's on a weekend, but still, sometimes if you're really concerned, and I am, if we're really concerned about what's in the best interest of the people that are Georgians that we serve, sometimes you do things that you don't get a paycheck for. You just do it because it's in the best interest of who you're serving. So sometimes you might have to go and do that on a weekend, give up a Saturday evening to go and pop up and just say, hey, here we are. So I don't know what that answer is, but in the age of communication where everything is in our hand, we should be able to know how to go somewhere, where we need to go if we don't have access, if we don't know where to go, right? Does that make sense to y'all? So anyway, I just wanted to make that comment, and thank y'all so much for what you do.
Thank you, and thank each and every one of you and your organizations that you represent. You're a great asset to our state, and we really do appreciate it. Thank you.
Thank you.
Okay, we are going to take a 10-minute break and come back and Presenter, we have Megan Andrews with the Department of Public Health. The mic is yours.
Hello, there we go. Hi, everyone. I've met most of you, but Megan Andrews, I'm with the Department of Public Health. It's great to be here today. Thanks for having me. I did want to go off script for a couple minutes to address things that were talked about previously and make sure I address some of those items. So the first thing is the funding formula. So there's really two funding formulas that have been discussed. The funding formula that is determines the allocations that the state gives to DPH, and then in turn we give down to the counties, is the general grant and aid formula that was actually developed in 2011 by the House and the Senate. So it's not as outdated as we think. However, what hasn't been updated in about 50 years is the formula to determine the county contribution to those county health departments. That has not been updated since the 70s. And that is determined by population and tax digest data. So I just want to make sure that was very clear because I could tell there was some confusion. The other thing I wanted to address was the co-location of FQHCs and health departments. That happens throughout the state. All of those partnerships are organically grown and happen locally, and we see great benefit of it. One thing to keep in mind is the county health department facilities, their actual building and location, is provided by the county government. That's in statute. So it's not anything that the state funds. They pay for the building and then generally the utilities and things of that nature. So that's just something else to consider if we're talking about co-locating and ensuring there's enough space to co-locate. That's something that the county governments would need to be involved in that conversation. Okay, I think that was all my off-script items. So I was asked to talk about the EMS system in Georgia. This, I can understand, is a complicated system, so I'm gonna try and explain it as simply as possible, and certainly happy to take questions at the end to help clarify anything for you. So the EMS system is established in statute. I have it cited there in case you ever want some light reading. And then our rules and regulations are also cited there that regulate the EMS system in Georgia. And then I also have our office's mission. We have an Office of EMS and Trauma, and I'm gonna go over what they do at the state level. So here's some history for you, and there's some key terms that I have bolded and underlined here to draw your attention to because you're gonna see them throughout my presentation. So the first is that the General Assembly declared in statute that in order to protect the public health and well-being of citizens, that the state must encourage, foster, and promote EMS programs, and that the program should be accomplished in a manner that is coordinated, orderly, economical, and without unnecessary duplication of services. So that's sort of the bedrock within which the EMS system is structured in Georgia and why we have a zoning process that I'm gonna talk about later. And when determining what the administration of the system should look like, that authority is delegated to DPH, so that falls within our purview and areas of responsibility. We work with local coordinating entities. That's what they're called in statute. What I am going to refer to them as are the regional EMS councils. And you'll see a map and I'll talk about who sits on those. And how this system is run needs to be consider economy, efficiency, and the benefit to public welfare. So all decisions that that council makes and the department makes are based on these three factors. So what does the Office of EMS do at the state level? So I have them kind of in buckets here for you. So the first one is we issue EMS agency licenses. So these are the ambulances you see driving on the roads. We inspect the trucks. We grant them their licenses, make sure that they're renewed and up to good standards to provide sufficient care. We also issue provider licenses, so paramedics, EMTs, these are all the various levels of providers. They're licensed by DPH, so they do continuing education. They get relicensed by us. We do like license removals or suspensions if there's issues with that. So very similar to nursing or physicians, we're the regulatory body that license the actual providers. And then we also do hospital designations. So trauma centers, stroke centers, cardiac, all of those levels of care, they apply to DPH, and we do the inspections and certify them as meeting the standards to be a level 4 trauma center or whatever designation they're seeking. So when we're talking about EMS service delivery models, there are a few different types, and so I just want to go over them real quick. First is a governmental EMS service. So that's usually a county-run or a fire department ambulance service. In your folders, you actually have the zone providers for the entire state. And you can see the majority of them are county-level providers. That's the county government running the EMS service. There are private providers, so they're not associated with the county government. It's just a private company that runs an EMS service. There's hospital-based services as well, so where they're associated with the local hospital. And so when we award a zone to an EMS provider, there's really two mechanisms in which they can provide services. One is a direct service provider, so that ambulances or EMS agency is awarded the zone and they are the ones providing the service. There are others where we award a zone and then they contract out the services to another provider. An example of that is in DeKalb. So the zone provider is DeKalb Fire and EMS, and they contract out with AMR to actually provide the services, the 911 services, day to day in that county. So Georgia's EMS system. DPH is responsible to ensure that there is an EMS agency that is responding to 911 calls in every zone in Georgia. For the most part, the zones are the county borders, with some exceptions. So as you can see, there's 159 counties in Georgia, and then 175 emergency response zones. So there are some counties that have multiple zones within it. And I have them listed here just so you can see that. There could be various reasons why there's multiple zones in a county. One, it may be a large county, either geographically or population-wise, and the proposals that we received requested, that zone be split into several locations. There may be municipalities that want to run their own zone, so during the zoning process, they said, hey, we really want to run our own service in the city of Brookhaven, or whatever it is, and so through that, they can apply to run their own zone. So that those counties that are listed in the parentheses are how many zones are within those counties. And then we do have 2 counties in Georgia that actually share one zone. So that's Oconee and Clark County, and there are 2 designated zone providers for that zone. So they run calls together and work collaboratively to cross county lines and provide services. Every zone in Georgia has a designated provider, and both the provider and the zone lines themselves are determined through a zoning process that I'm going to talk about. So several slides back, I talked about the regional EMS advisory councils. They're located another map of Georgia with different lines. There you go. The REMSAC is the local coordinating entity that statute designates to evaluate and recommend changes to the ambulance zoning process and providers in their region of the state, and they make those recommendations up to the commissioner of DPH, who then issues the final decision. Here are some of their objectives. They also, in addition to doing zoning, they promote training programs. They also take complaints. So they serve as a public forum. All of their meetings are public too. They're posted on our website. You can go listen in if you want to your region's EMS meetings. But they'll take public comments and concerns and complaints. And I'm gonna talk about how that plays into the zoning process here in a minute. They recommend to the Commissioner of DPH the designation of the 911 zone providers within their region. We are starting to do quarterly reviews with these regional EMS councils, so they're going to be looking at key performance measures for the ambulances within their region to see how they're performing and if there's room for improvement. So we're starting to provide those quarterly data runs for the councils for them to review. So who's on these EMS advisory councils? That's established in our regulations. The representatives are listed here. There's appointees by the County Board of Commissioners, representatives of the different providers of care, representatives from the different EMS education providers, as well as the different agency license types. So the zoning process. These REMSACs are responsible for coordinating and facilitating the improvement and maintaining a quality EMS system within their region. When they're presented with a complaint and that can come from anyone. It can come from a mayor, it can come from you, it can come from anyone. A member of the public can submit a complaint and request that they examine the zone and the performance of the EMS provider. And there's those three terms I said again at the beginning. The plan has to be based statutorily on those three things. So if a REMSAC receives a request or a complaint regarding an emergency response zone, they look first to see, is that complaint related to those three statutory terms: economy, efficiency, and benefit to the public welfare. Before they move on to the next step, they need to make sure that the complaint is relevant to zoning, not, I didn't like how that guy looked at me, or I didn't like his shirt. You know, we get all kinds, I'm sure you guys all get all kinds of complaints. So we wanted to make sure it's relevant to the issue at hand. If it is, we move to the next step. That council conducts a very detailed examination and an assessment of the key performance measures for that zone. They look at, we have a lot of data in EMS, a lot. And so we pull performance data looking at those measures, and I have a couple highlighted here on that slide. There's a lot more, but the two at the bottom are just some examples of the data we pull. So the percentage of STEMI patients that were transported to the correct hospital. Getting the patient to the right hospital the first time is really important, and so that's something that we look at. The percentage of stroke alert events in which the ambulance arrives on scene in 15 minutes or less. That's a goal that we have for the EMS agencies across the state. These are really time-sensitive situations where they need to get to a hospital and get care within a certain amount of time to have good outcomes. So after the council's done looking at all of that data, they ask themselves several questions. Has there been a significant decline in the performance of this EMS provider? Or is there an opportunity for significant improvement in the service delivery? If yes, then you go to question 2. Can this existing provider address these concerns? So is there an opportunity for improvement? If so, they usually give that zone provider about 6 months to improve. And they come back after that timeline has elapsed and relook at the data. At that point, they determine, has the provider addressed the concerns? And if not, let's open the zone. And the zoning process is really similar to a DOAS procurement process. It's a competitive bidding process. So I'm going to go into that now. If the REMSAC votes to open a zone, DPH reaches out to all of our licensed ground ambulance services. So like I said at the beginning, we inspect those trucks, we issue those licenses, we know who these folks are. They are all put on notice with the relevant dates of the zoning process, as well as important statistical information about that zone. So we have all of the call data, all of the EMS run data, so we provide a lot of that in aggregate form to make sure that the bids are based on actual data. So the zone proposal applications are received and scoring rubrics are given to the zoning committee. Usually the full REMSAC doesn't review all of this data, they appoint a subcommittee, a zoning committee, a smaller group, to really dive into it and give it more detail, and then the full committee eventually votes on the recommendation. So that zoning committee reviews and scores and makes recommendations to the full council. The council reviews the zoning committee's recommendations and then votes on the final recommendation of the regional council. It's then sent up to the commissioner to make a final decision. Some things you should know about the zoning process. The zoning plan, essentially those bids that are received, can include things like changing the zone themselves. So, if there's a municipality that wants to run their own zone, they could partner with the county government and say, hey, let's submit a proposal together. We'll run our municipal zone, right, and then you run the county. And they work together to submit a proposal. So that could happen through the zoning process. A zone can be split, zones can be combined. Really, the committee is looking to address those three things in statute: economy, efficiency, and benefit to public welfare. The other thing to consider is that zone proposals from providers may include a requirement for a subsidy from the county government. In those parts of the state where there's a high uninsured population, in order to maintain a sustainable model and knowing the reimbursement that the EMS agency may or may not be receiving, they may require additional funding from the county government in order to run a service there. And that happens several places throughout the state. The most recent one that comes to mind is Augusta, when they went out for rezoning a couple years ago. And that's all based on that data that we provide them during the procurement process. So we also include the payer mix for that region or that zone that they're bidding on, so they know how much uncompensated care is going to be there, the number, and they can help determine the number of ambulances to adequately cover that region. Typically, we'll also have in mind what we think is necessary for that region, and so the regional council will take that into consideration. If someone submits a proposal to run one ambulance 24/7 in a huge county, that's going to be insufficient to be a benefit to public welfare. So we'll also have in mind, based on the data, how many ambulances we think are necessary. Okay. I'm also going to talk about a few universal issues as it relates to EMS around the state. The first is wall times. I'm sure you guys have all heard this term, but if you haven't, that's the amount of time that an ambulance spends sitting either on a wall or in a hospital lobby waiting to transfer care of that patient. They can't just drop them off and say, here you go, and leave. They need to physically transfer that care to the hospital staff. And with the workforce shortages, really any health entity is facing, there's been challenges in rapidly transferring that care, especially when we're in high volume seasons like flu and RSV season. So that's been a challenge really since COVID. So that's something that has been going on. We've been trying to work on and address. We have reports on our website now if anyone wants to look at wall time data. And we also have a task force that the EMS, yeah, I can take a question.
We have a question.
Yeah.
Thank
Chairman
Thank you,
Hatchett.
Chair. While you're talking about wall times, can you dig a little deeper on, to me, it makes almost no sense. It makes no dollars, I know, but what is the reasoning? How does that happen? Go dig I just want to hear your
My
explanation.
thoughts? Yeah. I mean, when we're having high volumes in our hospitals, either emergency rooms or otherwise, there's challenges with enough workforce to cover the number of patients they're trying to serve. There's lack of beds, actual beds to transfer the patient, or workforce to cover, right, provide care to that bed. So, and why this is challenging and like the downstream effects is that ambulance is off the road now, right? They're not responding to 911 calls because they're sitting in a hospital lobby. So we're we've been really trying to promote collaboration between EMS agencies and hospitals to facilitate a rapid transfer of care. But there's challenges, right? Like those relationships really need to be organically grown and happen. They can be encouraged by the state and regulators and all of that. But it's up to the local EMS agency and the hospital to develop their procedures in order to facilitate that rapid transfer of care. But yes, I think it's a staffing issue and a bed issue.
Representative, you want to say something? Representative
Okay,
Sharper?
thank you. If you really want to know about wall times, I can tell you what leads to a lot of the wall time. Like you say, when we get to the hospital, I haven't been on the truck for a year or two, but when we get to the hospital, and you may have a trauma situation already going on in the emergency room, and you have no beds available. So that means that if something's going on, or sometimes you have, behavioral situations where you just got to have a room taken, until somebody come, for crisis center, and that's another issue on top of that. But like you said, the transfer of care will be inside, and you got to wait till the doctor either decide, okay, we're going to discharge this patient, or we're going to get a room upstairs, we're going to keep for admission. So that's another thing that really hurts that wall time, and we're standing there, trying to wait on them. Everybody's working hard as they can. The workforce is working. But another thing is the education to the people that come in by ambulance. A lot of people think that if you call the ambulance, you're going to get to the back and get into a bed quicker, or you're going to be seen quicker. So what has to happen, and what we see needs to be done more, is educating the people. I've been on the scene before, and with a patient, and someone say, hey, just call the ambulance, and you might have 30 cars in the yard, and it's not very, very major that they need the ambulance. They need care, but you don't really need the transportation, right? But they don't want to wait, and they say, somebody in the corner is going to say, well, call the ambulance because you can get back there quicker. And you hear that even when we get on scene. We say, well, any reason, we're going to take care, but any reason why you didn't, oh, well, they'll see you quicker in the back. I say, no, they won't. Because what we had to do is, working with the ambulance and the hospital and the ER, even if you came by ambulance, if your particular situation, emergency, doesn't need quickly emergency care, then you're basically going to say, okay, we're going to take this patient and we're going to take over the care. They're going to be sitting in the lobby, or they're going to be in a triage, more of a triage area, versus taking up a room. And so by us making those changes and also educating people, maybe that person that you went and picked up last time, when y'all came in the back of the ER and they ended up out there in the lobby, the next time they have an emergency that doesn't require ambulance, they say, well, you know what? Y'all just take me because I'm going to get put in the lobby anyway. So it's more of an educational issue, but that's why we have the wall times. A lot of different things lead to it, but I think we're moving in the right direction of educating, also putting the person in the lobby if it's not emergency care. So
That's, and I haven't done what you've done, so I mean, it makes sense. Okay, you did take them, and because you thought it was emergent, or maybe you didn't, maybe the EMS knew it wasn't emergent, but so then there's the question, do they get paid if it was emergent or not? Or if it's a county system, they probably eat it or whatever. But so you brought them to the hospital here. I mean, okay, you got to wait in the ER just like I do if I walk. So, I mean, I don't know how we.
You can't just dump them.
There may be laws. Okay, I
Yeah.
don't know.
it's not set up like that right now. So it's really the liability of that hospital to be able to say, hey, look, I'm going to sign for that patient. Because we've had that and say, okay, we're signing for it. They're going to be, now it's on them.
Yeah.
They go to the lobby. You know what I mean? So it's just communication,
I think a lot of this is going to be liability. Until you transfer that patient, it belongs to the EMS, and until a
Right.
doctor in the ER or someone signs off for it,
Yeah.
then it becomes the responsibility of the hospital. That's
Yeah,
what
and I think
it needs
there's-
to be sped up. I have no doubt about that.
Right.
But I think it's a liability issue.
Right.
It's a liability issue, but I think on the behalf of the EMS people,
Yeah.
they also have to try to educate them in a good way, not in a bad way. You know what I mean? Like, well, you don't need to go out. Now you're out there. Now the liability. You came out. You didn't take care of that patient. You didn't get them where they need to go. So now it's on you.
Yep.
But really to encourage them, hey, you're not necessarily gonna get in the back and get. You could be in the lobby. In your situation, maybe a lobby situation
All right,
with
thank you.
liability.
Yeah, and I think
Continue. I'm
there's,
sorry to interrupt, but that was
Oh, no.
pressing. Thank you.
happy to take questions. I think there may be some EMTALA at play too, the federal laws. I'd ask GHA to provide more information on that, but I think that there may be some implications there. And that brings into a couple other things that we've been working on. That's on my next slide, but I'll talk about it now because I think it's relevant. One is that EMS services aren't reimbursed unless an actual transport occurs. So one of the things that we've been talking about and looking at in partnership with DCH is two different things: treatment without transport. So if they could treat the patient on the scene and not take them to a hospital, they have a sprained ankle, they're elderly and home alone, could they treat them on scene instead of transporting them and then getting reimbursed for providing that care? The other one is treatment to alternative destinations, and that's something that Dr. Toomey worked very closely on with DCH, and Medicaid has opened up reimbursement codes to allow EMS agencies to transport to alternative destinations. So if someone has a sprained ankle or something like that, they can transport them to an urgent care or another care facility instead of a hospital. Because prior to that, your only option was the ED. So that's something that we've also done to try and address this and have been working on collaboratively with our partners. So I won't cover that on the next slide, but I do have it on there. And reimbursement, I highlight up here that there's only reimbursement if there's an actual transport. The workforce issues that are impacting hospitals and public health, and they also impact EMS. There's workforce challenges there, finding enough EMTs and paramedics to staff ambulances. Interfacility transports are also a challenge. So that EMS zoning I talked about, that's really focused on 911 response. So ensuring that when you dial 911, there is an ambulance that will come to get you. Interfacility transports are challenging because when you are needing to transport someone to a higher level of care that may be hours away and several counties away, that takes that ambulance out of service. And I know that that's something that, Chair Taylor, you've been talking about for years, and it's a challenge all around. So I think there's some things we have talked about over the years, and but definitely something to work on too is interfacility transports. And then the future trends, there are several community paramedicine programs out there where the paramedics will come do essentially home visits to provide care to patients. Usually it's after like a hospital discharge, and they have follow-up care that's needed. So those exist throughout the state. I could see those expanding more. The use of telehealth and EMS to call a provider to help guide care during transport. Treatment without transport, that was one of the things I talked about, has not been solved as far as reimbursement goes yet, but something to continue working on. The alternate destinations, I talked about that as well, that's now being reimbursed. Telephone CPR by 911 answering points. Y'all had a bill about that a couple years ago, but when you dial 911, a 911 operator can walk you through administering CPR until first responders arrive. Tiered response systems, so that's when there are different types of vehicles that could get to the scene faster. So they may not be a full-blown ambulance that can put someone in the back, but they may have some providers that can provide first aid and immediate services and address some of those workforce issues. There could be more of those in the zones that are being served, and there are some that administer tiered response systems. So they'll provide care until the actual ambulance can get there. And then move to try and decrease use of lights and sirens. We know that that's always can cause public safety issues on the road. People don't really know what to do when there's lights and sirens behind them, and can cause accidents. So not every transport requires lights and sirens, so trying to cut down on use on that for true emergencies is something else that the state is moving towards. So I'm here for questions on this or other topics, if you have them.
I have a couple quick questions.
Yeah.
I know the ambulance service in general is under the purview of the Department of Health. But we look to our counties to provide it. Are there counties, because I have heard tales of counties that have no ambulance service. I don't know if it was temporary or they didn't have an arrangement or things like that. Okay, and then I've also heard of one that it can't go outside its county borders. It was a county-owned, and it couldn't go outside the county, and they picked up a woman on the edge of the county, brought her to the hospital. Their hospital doesn't deliver babies, and she was about to have a baby, so they had to call another ambulance to come get her to take her out of the county. Are those things that would be regulated under a region? How does stuff like that happen?
Yeah, so your first question, there's an ambulance that responds and is designated as the zone provider for every area of the state. And actually, for each of you, I printed individually your district's zoning plan. So you can keep that, but it's specific to the districts that you represent. So there is and should be coverage for every county. There is a designated zone provider, and you have that list. As far as transporting out of the county, one of the challenges is when counties provide that subsidy that I talked about, and yours, it sounds like, was a county-run service.
Mine is county. That did not happen in my county.
Okay.
It was another county.
When that
Clarify
subsidy is being provided by the county, they contract with that EMS agency that will give you this subsidy, and here's our expectations, essentially. And so there may be things in that contract that is prohibiting them from leaving county lines. I could see that being something that is in there. I have also, we've started seeing an uptick too in those subsidy contracts that counties may be adding language saying your first priority is 911 response. Like, you cannot do an interfacility transport and leave the county uncovered, which further exacerbates the interfacility transport issues. So, there's downstream effects of that too, right? It's keeping a bed occupied that they need to be transported to a different location. So, it's a hard topic, but.
Thank you. Representative Sharper?
Okay, I'm going to speak to that just a little bit.
Yeah.
Sometimes when you have maybe one ambulance in the 24-hour ambulance in a particular city. Now, I will say this: a lot of the counties, they have mutual aid agreements that if they're gone and they're wall time outside the county to somewhere else, to another hospital, that they have mutual aid just in case a call comes in Thomas County, that Brooks County or one of the other counties, they can go in and work in that county because you have a mutual aid agreement. In a situation of, let's say you have a small little hospital, let's just say Lakeland, Georgia, and you have that OB patient, sometimes they've had on-call crews, or depends on how quick they got to move. Hey, mutual aid is in, be on the lookout for us if anything happened. Lowndes County, they're going to go to Lakeland, Lanier County, if they have a 911 call, if that particular one has to go. Now, if you're in a city and there's maybe one county and has that one ambulance, and they take them to the regular hospital in the county, if they have that agreement to say, okay, you can't leave, then at that point, either a private ambulance service can come in and take that patient from that point to maybe Phoebe or another place, of the specialty care that that patient needs. But there's so many different variables. Even in Lowndes County, we have several non-emergency private ambulance companies that are there that take maybe dialysis patients, cancer treatment, discharge from the hospital. But at the same time, Lowndes County, they do as many as they can of their own, discharges to the nursing home and other places, and also going to Atlanta, going to Tallahassee, going to Jacksonville. But then when they run out of that, they don't bother the designated 911 trucks to go out of town. That's when they may call a private service and say, hey, look, can you take this patient to Tallahassee? Because all of our non-emergency units are out, and we don't want to top our, designated county trucks. So there's just so many different variables.
Yeah.
But mutual aid is a big thing that helps out a lot of these different counties, even the bigger counties.
Yeah.
Thank you. Chairman Hatchett?
That's fine, thank you. So I'm gonna tell a little story and then ask the question.
Yeah.
So several years ago, I don't know if this is still happening now or not, but a county that happens to be on I-16 where inevitably people fall asleep and have an accident, they have I guess with the RIMS Act, it's in a certain zone, and I guess each county has to have at least an agreement with an ambulance or EMS provider.
Mm-hmm.
But this county, they did not have an ambulance that was actually housed in the county, but they had access to a service, and they could not get the provider to have an ambulance present or two. Is there, to your knowledge, is there anything in the code somewhere that says a provider has to have a physical ambulance present in the county? I know they got to provide service, but you follow my question?
Yeah.
So there were people that were not getting care as quickly as they probably could have had the ambulance been in the county.
Right.
It was having to drive from where it was 30 minutes or so. Then, and a lot happens in 30 minutes.
Yeah, yeah. So for the most part, like I said, the zones are the county borders. So the zone provider should be within those counties, or the county borders. That it's not in statute, it's not in regulations. It would be in the contract that they sign when they're awarded the zone. I can pull a contract. I'm curious too if there's a requirement of physical presence.
Because you had quite often, you'd have sheriff's deputies putting people in the back of the car
Right,
or whatever, and
right.
getting them where they could as
Which,
fast, but
right.
they can't give any care.
Right,
So,
which is not the intention, yeah.
thank you.
Chairman Parrish?
Megan, let me ask you, for the past few years especially, the House has been trying to push more behavioral health facilities and beds. And one thing behind that was that so many of the ambulances were tied up with wall time, like they were talking about, when they would have an involuntary admission to a hospital for a behavioral health issue or something. Have you been able to determine yet, is that helping? I know it's relatively new, and we're trying to add more beds and facilities every year, but have you been able to tell, has that made a difference yet? Can you see anything in that?
Not that I can tell. We can probably do a specific data run on mental health condition EMS runs to see, because like I said, we have access to a lot of data. I don't know offhand.
Yeah.
I think really the impact on wall times is primarily those high volume seasons, flu, RSV, COVID seasons where the hospital is just overrun. I think the transfer of a mental health patient is more complex and challenging to actually transfer that care. But we can pull like a data run for the last year and then previous years and see if there's an improvement on those like wall times for mental health runs.
Yeah, thank you.
Yeah.
Well, I'm gonna go ahead.
Go ahead. Okay, go
I'm
ahead.
gonna address that. What we were able to do, because usually whenever you have to take a patient in, behavior-wise, and no other emergency care, they still have to get in the ER room. It's got to be secured. You got to have somebody actually sit, outside that room or inside that room. That's another workforce situation until somebody get available to come evaluate that person. But we've been able to get with some of the crisis centers and certain things that we can go from home and take that patient to the crisis center versus going to the emergency room. And I think there's some pilot programs that they're trying to do to do that more. Of if the crisis center is suited, but there's no other medical history, no, like emergency needs at that particular time, that we can take that patient to the crisis center.
Yeah.
And that'll free us up and free the emergency room up.
I don't see any more questions, but a comment I would like to make, and something to think about. We've had discussions about having community health workers. I think some of those would be very beneficial. Is this something that you could see coming under your purview at the Department of Community Health to help us to regulate, develop what they can do and what they cannot, skill levels, things like that? It could help with the ambulance service, but I think it will also help hospitals and ERs where people won't show up because they got off their medicine this week. Things like that. Is that
Right,
something you would
right.
encourage?
Yeah, I mean, and you're gonna hear, when you hear from the home visitors, that's really been the cornerstone of the home visiting program is, and they'll go into this in more detail. I mean, we love this program, but there's federally funded home visiting, but they give you, a list of 8 different models you can use, and nothing really fit Georgia. There's, the closest thing was something called nurse-family partnership, where the home visitors are nurses, which is great, but it's expensive and not sustainable, to really touch the whole state. So if you ever hear Dr. Toomey talk about her service in in Alaska, and very rural Alaska, she relied on community health workers. They're trusted, especially when you're letting someone into your home, right? Like they want someone from the community that they know and they can trust, and to open up to them, that's when you're gonna have the greatest impact. So we love community health workers. We think that is an untapped resource. We're using them as much as we can in our home visiting program, but I think expanded use in all medical care settings is really, really important. So,
Thank you very much. We
Yes.
appreciate all this great information.
absolutely.
Okay. Our next speaker will be James People. If you would come up and introduce yourself. Thank you.
So before I start, Brandy's, our Legislative Affairs Director, Brandy Sylvan, is going to make a comment.
Hi, I just wanted to, real briefly, I'm Brandy Sylvan, Director of Government Relations with Department of Community Health. Just wanted to follow up on one of the points Megan was speaking to about treat without transport, and that is actually a code we've opened up in Medicaid. I didn't necessarily come prepared to speak to it today with all of the data and everything, but I'll be more than happy to follow up with Morgan after this email and give some clarification on that policy and reimbursement and utilization. So just wanted to add that in before James can really give you all the information you'd ever want about NEMT.
Thank you, Brandy. Good morning, everybody. We're still in the morning. I'm James Peoples, Director of Provider Services with the Department of Community Health, which is a partner agency to the Department of Public Health. In my unit, Provider Services includes non-emergency medical transportation, which is what I'm here to speak about today. So it's a great segue from all the discussions and all the talks we've been hearing about transportation this morning. So I'm going to tell you about Medicaid non-emergency medical transportation. A little bit about me. I've been with the state for 27 years. I like to tell people I'm in the 4th quarter of my career, so I'm real excited about that. I work under Stuart Portman, who works as our Medicaid chief, and of course our new commissioner, Dr. Dean Burke, one of you all's former colleagues. We're all super excited to be working with Dr. Burke, and we're looking forward to his leadership. So I'll get right into the presentation, and like I said, I'm with the Department of Community Health, which is different from public health, but we work together and we partner all across several different spectrums. And I'm going to tell you a little bit about how we partner with transportation near the end of this presentation. So at DCH, our purpose is to shape the future of a healthy Georgia by improving access and ensuring quality to strengthen the communities we serve. We call our members, our Medicaid recipients, we call them members. So you may hear me say members pretty frequently, but we work with our providers and our members to take care of our members. Our mission is to provide access to affordable quality health care to Georgians through effective planning, purchasing, and oversight. We are the state's Medicaid agency. Every state has to have a designated state agency to be the Medicaid agency. And in Georgia, that is the Department of Community Health. Okay, what is NEMT? A lot of people are not clear sometimes what NEMT is, and we actually added the M a few years back because it used to be called NET, and the problem with that was you had people calling us for transportation that was non-medical related, and we can only transport for medical purposes. So we put the M in there just to make it more clear for folks. But NEMT is a program that provides medically necessary transportation for eligible Medicaid members who have no other means of transportation available. You can't have a vehicle, own a vehicle, and use the NEMT services. It is specifically for members who do not have any means of transportation to get to and from their appointments. And then we're restricted in terms of what types of transport we can provide or where we can take people to. So one is to receive medical treatment, which is just your basic medical appointment. They can also ride with NEMT for medical evaluations. We will take you to the pharmacy to get prescription drugs. And then you can also go to your healthcare provider for medical equipment. In addition to these 4 areas, we also do hospital discharges, which I'll speak a little bit about in that partnership with EMS later. And then we also transport to adult day health facilities. So those 2 areas are also allowable transports for NEMT. How does the program operate? So what we do at DCH is we provide transportation through what we call the broker model. It's important to note most states use the broker model, and by the way, Medicaid transportation is now a mandatory benefit. It used to be optional. Georgia's always had one, but some states did not have NEMT. But I think right around probably 2021 or so, it's now a mandatory benefit. So if you're a state Medicaid program, you must offer transportation, the transportation benefit to those eligible members. And the way we do that in Georgia is we use the broker model. And you guys have probably heard of our brokers. I'll talk about them in a second, but we've divided the state up into 5 regions: Atlanta, North, Central, East, and Southwest. I'll show you a map in a second. And then the broker is who we contract that delivers the transportation. So we pay, the DCH pays the broker, and then the broker contracts with the individual transit providers. And you've probably seen some of those vans riding through your communities. They're not ambulance vans, but they look kind of like an ambulance without the siren on it. So you may have seen some of those vehicles riding through your community. But we do not contract with the provider. We contract with the broker, and it's the broker's responsibility to build a provider network. And the broker is always trying to recruit new providers because, as we've heard, it's a challenge across the state, especially in rural areas where you just may not have enough providers. Who are the brokers? So in Georgia, we have 2. Motive Care is one. They service the Central, East, and Southwest regions. Motive Care used to be called Logisticare, so you may remember them as Logisticare. And then Verada is our second broker. They provide NEMT service in Atlanta and the North regions. They used to be called Southeast Trans. You may have heard of them before as well. Those are our current 2 brokers. This is a map of how our regions are designed for NEMT purposes, and I know they're different from the public health map, different from some of the other maps you've seen earlier, but it's important to note that this map is it's more of a transportation type of structure that we had to build as we developed our regions. So the North and Atlanta, that would be Verada. They are the broker in that area. And then the East, Central, and Southwest, the broker is Motive Care. So the brokers use the most appropriate mode of transportation according to a member's level of service. Ambulatory is for members who have basically no physical restrictions. They can, board the vehicle without any assistance. They can ride in a standard, NEMT van or a sedan or a vehicle. Then we have wheelchair transportation, which is another level of service, so it's a higher level of service for those members who are in wheelchairs. It's important to note that our ambulatory transport is curb to curb, and wheelchair, though, is door to door. So that's from the door of where we pick you up at your house or the nursing home or wherever, to the door of the hospital or the health clinic, wherever you're going. Then there's stretcher, which is bed to bed. Most of these trips occur from our partners at the nursing facilities. The skilled nursing homes is where we do most of our stretcher trips. It is important to note, and we hear this all the time, is that when the NEMT vehicle picks you up from a nursing home and puts you on the NEMT stretcher, it is the responsibility of the healthcare provider who's doing the treatment to have a stretcher available for that member to be transferred to. We are not able to transport and then have the member be treated on the NEMT stretcher. Purposes for that is because that stretcher has to go to pick up someone else. So we hear this a lot. We get a lot of calls about this. We get a lot of calls from healthcare facilities saying, hey, we don't have a stretcher, or we're not able to treat the member if we can't treat them on the NEMT stretcher. So that's one of our challenges that we're trying to work through, but we always try to keep our healthcare providers informed. We also will do public transit. So in cities like Atlanta, Augusta, Savannah, Columbus, there's a public transit system that members can use to go to their doctor's appointment. A lot of members like public transit because what they get is they get a token or a card, for example, a MARTA card in Atlanta, and they have to go to their doctor's appointment, but they can use that card to go other places too. So a lot of people like to do public transit if they're able to ride public transit. We also do Uber and Lyft. We were one of the first states in the country to offer Uber and Lyft to our Medicaid members. So we're really proud about that. And then we have volunteer drivers, which are people who get gas reimbursement. So we do have some mileage guidelines, mileage limits. And yeah, stop me. Oh, I was about to say, stop me if you guys have any questions.
When you mentioned the volunteer drivers, okay, do they use their own personal vehicle, or do y'all have vehicles available, and how do y'all go about the liability with that?
So that's a great question, Representative Sharper. Under the traditional broker-provider model, there's requirements in the NEMT policy that speak to a provider that might have a van or wheelchair van or stretcher van. Those policies are a little more restrictive, and the liability is a lot more cumbersome, if you will. But for the volunteer driver, it's only gas reimbursement. So if they have a valid Georgia driver's license, they're an adult, and they have insurance on their vehicle, they are allowed to be a volunteer driver. They'll still have an agreement with the broker as if they were a provider that's got a fleet of vans or a fleet of vehicles, but that agreement is much more condensed than what the regular provider has, because all that person is doing is getting gas reimbursement. So if they've got insurance on their vehicle, then they can become a volunteer driver, provided they meet the other criteria.
Okay, and so therefore, if you have a family member that want to be a volunteer driver for that person so they can get gas reimbursement, but do y'all also require that that person contact their insurance company to let them know that they're doing something of this nature?
So you're saying, is it the responsibility of the volunteer driver to let their insurance people know that they're taking people to doctor's appointments, that sort of thing?
Right.
Yeah, that's not a requirement in our agreement, but it could be in the broker agreement with that particular volunteer driver.
Okay.
So each individual volunteer driver would have their own agreement. It's a standard agreement, but they may have something where, depending on the type of insurance they have, they may have to notify their insurance carrier to participate in the program. If they don't, then it's not something that we necessarily require. We only require that they have insurance on the vehicle.
I've got a question. I need to go back a page.
Yes, ma'am.
To the regional setup. It just seems funny to me to go from Hart County to Clinch County. There's a big area there, and that's just, yeah. Southwest doesn't look much better, but How did they determine this? Is it population? Is it area? That just struck me.
Right, that, when you use the, what we use for the broker model, we use a capitated per member per month. That's how we fund the broker program. That's how we pay them. So there has to be a distinct number of people, and in this case, Medicaid members, in enough counties for the broker to be able to operate. So if they only had, the reason you see Atlanta is it's only 3 counties is because the population in those 3 counties is much greater
Of Medicaid recipients.
than some of those other counties.
Of Medicaid recipients.
Of Medicaid recipients, yes, ma'am.
Medicaid recipients.
And so it's structured that way so that some of these are travel patterns. For example, Augusta down to Burke County and down to Savannah, that sort of thing. But it's primarily driven by Medicaid population in the counties. And so you have all these counties, and it looks like a large area, a large swath of area.
Oh, yeah.
But when you do the numbers on the Medicaid members in those counties, it's pretty consistent throughout.
Okay, yeah.
Okay, it is such a wide swath of area there that you're covering. And are the brokers paid a PEPM or something each month, whether they take them for a ride or not? It's just
Yes,
based
ma'am.
on their block. I'd like to, if you could get us the numbers, how many in each one? And so it would be 1 broker in East, 1 broker in Southwest. Does any broker have more than 1 region?
Yes. So Motive Care has the East, Central, and Southwest region,
Okay.
and Verada has Atlanta and the North region. And I've got some,
Right, but-
I've got some numbers that I'm
Okay.
going to get to.
You
too.
can get that to us. It just
Okay.
seemed like a lot, and I'd like to see the numbers on that when you.
Okay.
Thank
Yes,
you.
ma'am. Any other questions on that, on the regional alignment? Okay. So we do have mileage guidelines, and part of the reason for our mileage guidelines is we don't want our members on the vehicle any longer than they have to be. The quicker you can get them on and get them off and get them picked up and take them back home, the better. So we put mileage guidelines in our policy. So for medical appointments, that's 30 miles urban, 50 miles rural. For adult day health, it's 15 miles urban, 30 miles rural. And for pharmacy trips, it's 15 miles urban, 30 miles rural. The broker can go beyond these mileage limits if there's a medical necessity. So let's say, for instance, you've got a member that's in a rural county and they need specialty treatment that's not available within these mileage guidelines. They can go beyond these mileage guidelines to get the treatment that they need. It just requires a physician's statement and a letter of medical necessity.
Can they go out of the state? For example, Clinch County may need to go to Jacksonville.
Yes,
Or they
50
can't.
miles across the Georgia border is how far we can go.
Okay.
Yes, ma'am. So we see that a lot in Columbus, Augusta, places like that, where we see sometimes members needing to go out of state. And like I said, brokers can extend these mileage limits based on member need. I spoke earlier about travel times for longer distance transports. Those are some of the things we try to be careful with, especially if you've got a stretcher trip from a nursing home member. We don't want that member on that stretcher in the vehicle for as long, no longer than they need to be. So we try to make sure that the broker follow the mileage guidelines. There's a lot of health and safety risk for the higher mileage transportation. We also have inclement weather that we have to talk about and think about, and then taking a transportation provider out of their service area. So that is why we created these mileage guidelines. Here's some numbers, and I won't necessarily go through them all, but this, Madam Chair, speaks to to a certain extent to your question about seeing some of the numbers. So I'll just do FY25 since that was the last fiscal year, and I'll just give you an example of what you're looking at here. So this is the total number of trips in FY25 for Verada in the Atlanta region. That's the top right column. You'll see gas reimbursement was 15,265 trips. There was 711 wheelchair trips that were gas reimbursement. You'll see over 1 million, almost 1,000,001 for the NMT provider. That's those providers, that's those transport companies that the broker contracts with. Paratransit, in some counties, there's a paratransit service. There's MARTA in Atlanta runs a major paratransit service, and you'll see the number of trips there. For the total number of trips on the ambulatory column, for 1.2 million. Sometimes people are surprised how many trips we actually run in NEMT. If you add them all up, it's about 1.3 million trips for FY25. And you can look at the numbers from 23 to 24, and you can see how trips in the Atlanta region are increasing. Now, if you go to that last row at the bottom, that tells you what the broker was paid for that particular fiscal year. And this is determined through their PMPM rate. And it's important to note that these numbers, the payment is not just for the trips, it's for the entire broker operation. Call center, insurance, technology, real estate, it's any cost the broker has to operate as an NEMT broker in Georgia. This is Verada for the Atlanta and the North, and Motive Care is next for the Central, East, and Southwest regions. I'll let you guys look at that to see if you have, or let your representatives, I'm sorry, look at that, see if you have any questions.
Representative Osteen, you have a question?
I do, thank you, Madam Chair. I was looking at these volunteer driver numbers.
Mm-hmm.
So looking in trips by region, this bottom right corner, volunteer driver are 0. So just looking at, they're all the same region, right? 23, 24, 25.
Yes.
So 23, the volunteer drivers you had for ambulatory was 2505.
Yes,
24, it's down to 428. And then 25, it's down to 0. So when I pointed this out to Representative Sharper, he said, you know, I wonder if it was worth the reimbursement. So what is the mileage reimbursement that you get to be a volunteer driver?
It's typically negotiated between that driver and the broker, but they will pay at the very minimum the rate that the state pays for mileage reimbursement if, like, I'm driving to this conference, that sort of thing. So I'm not sure what that rate, I think it's 58 cents a mile, something like that.
We went up to 70 cents now.
But at a minimum,
I think we're at 70 cents.
70 cents. At a minimum, it would be that. However, a volunteer driver may be able to negotiate a higher rate from the broker, depending on the types of trips that they're doing. If they're going kind of far, and, you know, if, let's say, they're taking a family member or someone beyond the mileage guidelines, they may be able to negotiate a higher rate.
So do you have a suspicion as to why the number has?
Why it dropped in the North region, I'm not totally clear on why it was 0. We'll take another look at that just to make sure. These numbers come from our broker reports. And we do know that Verada specifically have been using more of the rideshare companies, the Ubers, the Lyfts.
The Uber, Lyfts.
Right,
Okay,
right. And then
okay.
there's another rideshare company in Atlanta called Wings. They've been putting more trips on those services, which is probably why the volunteer driver number has decreased. Yes, ma'am.
I have another follow-up.
Yes, ma'am.
Where it shows the total amount, the 71, anyway, is that our portion, or is it combined, the federal and state together?
Combined,
It's
state and federal.
combined.
Yep. State and federal. I think the match is something like 66 to 40-something, 30-something, something like that, yeah. So you can see here in FY23 for Verada, it was 68 million, a little over that, and then 69, and then 71 million. And again, that is for the entire operation, not just what it costs for that broker to pay that provider to run a trip. It is everything that they have to do to be a broker in Georgia, in that region. And then the numbers there are for Motive Care, so the same data set, just showing you different numbers. All right, partnerships. This is something we always like to explain to our legislative our legislative team, our legislative members. We like to make sure that you all are aware that we do work with DPH, GEMA, and GDOT. A few years ago, we entered into a memorandum of agreement with GDOT and GEMA to help with hurricane evacuations. So when the governor declares a state of emergency on the coast, our brokers are able to partner and have some of their providers send assets into the area of concern to remove people, primarily the most vulnerable citizens. So we're talking about the nursing home folks, our seniors, to get them to safer areas. That's one partnership we have. We also will, when it's a snowstorm, for example, in Atlanta, we actually partner there to try to make sure that our members particularly can get their treatment, if it's like chemo or dialysis, some of those trips that, some of those appointments that you really can't miss, even though they're not emergency. They're still non-emergency, but you can't miss them because you'll end up in an emergency state if you're not dialyzed. So we try to make sure during inclement weather that we give the broker some flexibility to be able to do that. And then we also make sure that the broker keeps all the facilities that they transport to and from updated on weather notifications. And we do a lot of this work through GEMA and DPH, which is, and GDOT. What we've also done is created work groups for some of our constituent member groups. For example, the skilled nursing facilities. It helps us with complaints that we get from nursing homes or complaints we may get from adult day health. We created work groups where every month we bring the broker and the work group together, be it skilled nursing facilities, dialysis facilities, to talk about challenges, to talk about concerns, to talk about issues, things of that nature, so that we can reduce the number of complaints we get. When you're running as many trips as you can see us NEMT runs, there are going to be challenges, there are going to be issues, but these work groups can help us understand what the challenges are out in the community, where we might need more providers, transit providers, in what areas, what counties, what regions are we not fully staffed, things like that. So this has been critical in our work in terms of being able to reduce the number of complaints and the number of issues that our members experience when they request NEMT. You have a question, Madam Chair?
Your numbers, are these Medicaid only?
Yes.
Not Medicare, just the Medicaid? That's all we're looking at on these?
Yes.
Okay.
Yes, only Medicaid. Now, there is other programs with other agencies. DHS has a program that we work together with for members for people who are not on Medicaid. So a lot of times we'll get a call from someone who's not on Medicaid and they need to go somewhere. We can refer them to DHS's program. It's called Coordinated Transportation Services. We can refer them to that system for those people that we can't transport, or someone who may be trying to go somewhere that's outside of those parameters that I talked about earlier. Someone may need to go to the grocery store, for example. We can't take you to the grocery store. We can take you to the pharmacy. If the pharmacy is in the grocery store, you're in luck. But we can't transport you to places that are non-medical. But we do work with our other partners to make sure that those folks get transported when they need it to those other areas. And that is my presentation. I'd love to take any more questions.
I think you answered our questions. Thank you very much.
Thank
We
you.
appreciate this information. Thank
All right,
you.
thank you. And I'll follow up with Madam Chair on the volunteer route.
Thank you. Okay, our next speaker will be Christina Tice, and we're going to be hearing about the home visiting program, which frankly we're all excited about.
Yes,
Thank you.
Me too. I'll get it loaded for you. Great, thank you. Well, good morning. I think we're at the end of the morning, almost afternoon. Thank you to the members of the committee for having us here today to speak on this. Yes, that's us. Actually, it's the other one. The other one? Yeah. Great. This one? Yes. All right. So we're going to talk about the DPH Home Visiting Program. I'm the program director for the DPH Home Visiting Program, and very excited to talk with you today about what we've got going on in the program. First, I want to tell you a little bit about who we are and what we're doing. This is a home visiting program. We've got public health nurses that are trained and are trained community health workers that provide personalized care for women during and after pregnancy, as well as to their infants up to their first birthday. There is no cost to women for this service. We're going to get into this a little more in a little bit, but basically for the moms, a little bit of what we provide is we can check their blood pressures and vital signs in the home. We monitor their blood sugars. We screen for anxiety and depression, provide breastfeeding help and lactation support. For the infants, we monitor feeding, monitor their weight, track their head circumferences, and assess developmental milestones. And we'll get a little deeper into that here in a minute. Obviously, we have goals with our program, and it's to improve maternal and infant birth outcomes throughout the state of Georgia. We're getting data for you. We have performance measures. Of course, we want all of our babies to be born at 37 weeks or greater. That's what we call a term pregnancy, 40 weeks being the due date that you hear about. We want our infants to be born 2,500 grams or greater. We want all of our moms to complete their postpartum appointments with their providers, because that's so very important for follow-up care. Encourage the use of contraceptive methods by 6 to 8 weeks postpartum. And we want all our moms to be breastfeeding by at least at 3 months postpartum, hopefully further than that postpartum. So those are our goals that we're measuring and getting data for. So where did the DPH home visiting program come from? You all are aware of the Maternal Mortality Review Committee that reviews all maternal deaths in the state of Georgia. And over the years, there was resounding recommendation from the committee that home visiting would help prevent maternal death and maternal morbidity in the state of Georgia. So the state gave us funding to provide for perinatal home visiting pilot in the year 2023, in July 2023. It was determined that rural counties that have limited birthing facilities and OB providers would be the best targets to begin this program. The home visiting services would occur during pregnancy and up to 1 year postpartum to serve women. These pregnant women that we are targeting are considered high-risk pregnant women with identified risk factors that might put them at risk for poor outcomes in pregnancy and or in postpartum. So that's how we started. And that was just in fiscal year 24. The state gave us $1.68 million to pilot, and we piloted in 21 counties in 2 different districts. Given that, by June 30th of 2024, so just 1 short year ago, there were 14 home visiting staff in place, and 225 patients were already enrolled in the program. Now, fast forward to fiscal year 25, another $1.75 million was appropriated and given an additional state funding, bringing our total to $3.43 million. So with that, we expanded to 50 counties around the state, and you can see still in rural areas, and added 7 new districts to cover in this expansion. At the end of May, just a few months ago, yes, ma'am, I see you coming.
Representative Osteen, you have a question?
I do, Chair, thank you. Can you tell us what, and the reason I ask is because I'm from Coffee, where Holly's from. Turner and Irwin, neither one have any birthing facilities. I just wanted to know what is the determining factor of, choosing a county?
Very good question. And a lot of that had to do with where there was a dearth of obstetrical providers. and where the obstetrical providers are concentrated, because that is unfortunately where women are driving to get their care, right? So, and where the birthing facilities are. Remember, we've only got 69 birthing facilities, and well, soon to be 68 in the state of Georgia. So, very few. In May, the end of May, we had gone up to 46 home visiting staff and 582 patients enrolled. So more than doubled in a year's time with the number of patients enrolled. So the program has taken off like wildfire. Now, fiscal year 26 coming up in a couple of weeks, $2.98 million additional funding was appropriated, bringing us to a total of $6.42 million. With that, we are adding 25 new counties. You can see in the pink areas that we've highlighted here, adding 2 whole new districts to the services. Currently, we're in development of staffing plans, onboarding, recruitment of staff, and training staff for those areas right now. So pretty fast and fierce movement for this program. So now you're going to ask me, where do we get our referrals from, right? So of course, we want our referrals to come directly from maternal and infant providers, OB providers, pediatric providers, PCPs, the hospitals, EDs, NICUs, postpartum units, antepartum units, labor and delivery units to refer patients over to us. DFACS is a great partner in this. Other community organizations, providers, and partners also referring to us. Of course, health department programs are referring. And of course, we love it when patients self-refer. Like you were talking about earlier, we get out in the community and we table out in communities and present our program, and we get self-referral that way from patients. So that's wonderful. So, who can we take in this program? It's really actually a wide variety of women. You'll see that they can be covered from anything, people with hypertension, pre-existing hypertension, gestational hypertension, something called preeclampsia, which is quite a dangerous hypertensive crisis in pregnancy, women with diabetes that are pre-existing and or gestational diabetics, multiples, if you've got twins or triplets, great. Let us bring care to you where you are, women with prior preterm deliveries and preterm labors, chronic other conditions and comorbidities. For instance, I'll throw out there lupus that need more care. Prior second trimester pregnancy loss. You can imagine that that woman might have clinical problems and also some mental health condition from going through those experiences before. Women with prior fetal neonatal death. That's, again, another more mental health condition or clinical condition wrapped up with her case. Pre-existing health conditions, women with substance use disorder, and that can be women that are currently having a substance use disorder or in recovery. And mental health conditions. We find that that's our highest source of referral, is women with mental health conditions, anxieties, depressions, PTSD, coming to us.
If a woman has insurance, do we bill for it, or this is just a service?
Great question. Yes, if she's got insurance, we bill for it. So it can be private insurance, Medicaid, public insurance, or self-referral, self-pay. We will bill for that too. So there is some revenue back to the district. And of course, we also want women who have poor support systems at home. Let us come help them because they're having difficulty. Or those with difficulty complying with provider visits due to whatever issues. We've talked about a lot of those issues already today. For our infants, referral conditions for them might be those that were recently discharged from the NICU, those with very low birth weight or low birth weight infants that need more care and further, closer watching, those that were premature, less than 36 weeks pregnant, those whose moms screened positive for substance use at delivery, or who have suspected confirmed syphilis or HIV, or moms who've got a poor maternal support system at home. We want those infants to be in the program too, so that we can support them as well. Okay, so a little bit more about what we do. So our staff is trained in providing clinical care in the home, meeting moms where they are in their community. We can do blood pressures, vital signs, like I said, monitor their blood glucoses, help with making sure that their provider is getting the response on those blood glucoses and those remote blood pressure monitorings if we're doing that, so that the providers are constantly aware of what's going on with that mom. Monitoring her weight during urinalysis on them in their home, so we can pick up on any possible urinary tract infection, which, you know, urinary tract infection sounds like, okay, well, you know, those happen every day, but for a pregnant mom, that can be quite different and lead to preterm labor, preterm delivery. And we assess the fetus in the home using fetal heart tones as well to monitor the baby. Other things that we're doing in the home, we're constantly assessing and screening the moms for any complications of pregnancy, such as vaginal fluid leaking or bleeding, any other signs and symptoms of complications, such as severe headache. You know, that could be a whole constellation of things. That could be, you know, as severe as stroke or preeclampsia or hypertensive crisis. Extreme swelling in her hands or face, obviously abdominal pain, any changes she might have in vision. All of these, many of them play into a whole constellation of complications. Obviously trouble breathing or chest pain, fast beating hearts, and depression and anxiety. We screen our patients for depression and anxiety multiple times in pregnancy using known tools to do that, and we report back to our providers with our notes for every visit, so that the provider is aware of what's going on with their patient when they go in and see them on their regular visit. And of course, we're calling the providers and communicating to the providers if we find something outside of the norm, so that they can then advise how they want their patient directed, whether it's to come into the office and be seen, be sent to the nearest labor and delivery, or call 911 and get her to the nearest ED, too.
Is there any resistance if there's a referral, or do you find it mostly welcoming that the mother and patients are welcoming this help?
Yes, we're finding that the women and the families love the service. They love hearing about it. They love it when the nurses and the community health workers come into the home and assess the patient, and you know, they really find that they form a close relationship, a trusting relationship, and you'll hear more about that here in a second. But it really helps the woman feel supported, is all the feedback we keep getting, especially from her loved ones, knowing that there's somebody else out there in case they can't get to their provider's office, or they've got 3 children in the home and they can't get out as often as the provider would like over to the office. As far as infants, we're constantly watching them for feeding and for growth, you know, whether they are breastfeeding, pumping, feeding formula, or a combination of all of the above. Want to make sure that that's going well for that patient, or is there anything that we can do to facilitate any of that going better for that patient so that they can still help their child thrive. We measure head circumferences, and we're doing developmental screenings looking for milestones with the babies as well. Again, feeding back to the pediatricians anything that we find that might be out of the norm. As far as enrollment and staffing, again, we started in 2024 with 21 counties, 13 staff members, and 118 patients. That's at the beginning of 24. By November of 24, we'd increased to 50 counties, 39 staff members, and 380 patients, and that's just in 10 months' time. And then again, 7 months later, up to 50 counties, 46 staff members, and up to 626 patients, just at the end of this June. So it's really catching on like bonkers out in the rural communities, and we're loving it. Loving it. And the patients seem to be loving it. Providers, we're getting great feedback from providers as well. And we'd love to field any questions that we could.
Chairman Hatchett, you have a question?
Thank you. So are you able at this point to measure a success rate, if you could call it that, on how the program is working?
You know, we are collecting data quarterly, and we're putting together reports. We're coming up with a report, again, since we're still in infancy, if you'll have that. We will have that, hopefully, in the next few months. Where
So I'm going to put you on the spot. Would you say that it has, from what you can see so far, it's been successful?
Absolutely, absolutely. We're getting, you know, I can tell you a couple of the numbers that we've got. We've got 67% of women breastfeeding on discharge from the hospital. That's fantastic, right? We've got over 80% of women returning to their provider for their postpartum visit. That's fabulous. That's way higher than the national average, so that she's continuing care.
I would hope that this is now beyond a pilot program, and that the department would ask for funding to expand this statewide, because I think it's probably proving itself, and with all the interest and money that has been spent on reducing maternal mortality and maternal and infant mortality, and just all that emphasis, I think this is, if this doesn't do that, then I'm not going to say the rest, but I think we need to look at seriously expanding this across the state. I think we've done a great measured, but I think it's time. We can't wait.
We're with you 100% on that. We want to turn the whole state red and cover everybody, because everybody could benefit.
Representative Osteen?
I'm with Chairman Hatchett. I would love to see this go all the way through the state. I think it is imperative. I sit on the Public Health Committee with at least these two, and that's what we hear over and over again. Our rates are terrible. We're the 48th or 49th in the nation, and that's terrible. So I'm thrilled to see the numbers.
Yeah.
Can you just, going back to what you said, there are going to be now 68 birthing facilities in the state of Georgia. Will you clarify what that means? Like,
yes,
physician-wise, where they are. So there's 159 counties.
Yes, ma'am.
11 million people in Georgia, and women have not stopped having babies. So clarify exactly what that means.
So that means that that is a facility that has the capability of obstetrics, meaning helping women in pregnancy, through labor and delivery, and recovering in postpartum. Of course, other facilities can treat women, but in pregnancy, you want to go to an obstetrically inclined facility with OB providers that are trained and skilled, whether they're family practice providers with OB skill and training and or OB providers, the ability to refer to maternal fetal medicine providers, the ability to refer to neonatology, and bring all these providers together to give expert care to pregnant women and their infants.
That is an alarming number to me.
It's an
Should
alarming
it
number.
not make all of the
Yes,
hair on the back of our neck stand up?
It gives us goosebumps every
Right.
day. And we just got the word last week about the facility closing in now 30 days, I believe.
I don't know what that answer is. I'm also on another committee where we're talking about trying to get students in med school and rural students in med school, and then rural students going back and doing their internships and going back and practicing there for a while, and we're really pushing that. So I don't know what the answer is, but thank you so much for bringing this to us today.
Absolutely, absolutely. And yeah, and you'll hear from my colleagues. And you've got in your folders, I believe, some of our success stories about some patients that we found high-risk conditions on and really made an impact for them.
Thank you very much.
Thank
This has
you
been
very
very informative. If you would introduce yourselves.
So first and foremost, I am not a speaker like everyone else that is in the room. But when you said you wanted to expand it across the state, I actually want to cry a little. So I'm very passionate about our program. It is more than a job to me. And so when you said sometimes we don't always do things for a paycheck, yes, I do get a paycheck. But whatever ministry in your life looks like, this is a classic program that you can make your job your ministry. And I'm quite frustrated and angry that women in the state of Georgia die every day and infants die when there's no reason in 2025. And Dr. Callan, she left, didn't she? I have a Post-it note that has stuck on my wall for almost 2.5 years when I heard her speak the first time. And she talked about our health care and quality of health care should not be defined by our zip code. And I think this is what we see in maternal and infant health. So that's why I'm here today. I'm very passionate, so forgive me for not being articulate as everyone else. But so I'm from the, oh, thank you. So Angie will probably be embarrassed that she said we're from the same town after I get through speaking, but here we are. And so this is Sandra Gomez. She's a bilingual community health worker that is on my team and truly the hands and feet of what we do. So she is here with me, and we're glad there's medical people in the room. We're not going to pass out or have a heart attack, are we? So we're going to do well. But I just want to kind of tell you some stories. It's very difficult to show in data everything that we do because we could spend hours and hours of working with a mom, and we are truly, and these guys are truly the voice for those people that don't have a voice. And it may be because they lack education. It may be because they don't know where to go or they can't get there. So those are all the things that we'll kind of talk about. Let's see. So I'm from District 9-2, which is the Waycross district. I am housed in Coffee County, like Angie said. So these are the counties that we cover, 16 counties. So all of our district is covered with the program now, thankfully. And highlighted in red is where our staff are located. So you can tell we strategically place them all amongst the district so that we could attempt to meet the needs of the women's moms and families there. So that's our locations. And I'm the program coordinator. Certainly, we call ourselves in good old South Georgia the boots on the ground. So, and I say that with great honor, and I don't want to be anywhere else. So we get the privilege of going into their homes, and you guys know that it's not always easy to allow people into your homes to see your mess and dirtiness, but we get that intimate experience when they let us in there, and we're very thankful for that and don't take that for granted. So we have both part-time and full-time nurses who are RNs, community health workers, and 2 LPNs. So I'm going to pass. I'm enough in your presence. You don't need to see my picture. Just a little backstory. I came from the health department, so public health is my passion. Been a nurse for about 17 years, and 14 of those have been in public health, and then most recently to this position in the home visiting program. So these are my nurses. There's 9 of them that you see there. And she did a great job of kind of telling what the visit looks like. The nurse, primarily does the assessment, fetal heart tones, like we're looking for preeclampsia and the urine strip. If they're a gestational diabetic or a previous history of diabetes, we're going to, prick their finger and check for those. And we do catch a lot of things related to the urine, whether that be preeclampsia. The UTIs are a big thing in South Georgia, particularly when it's summertime. They don't drink enough water. So, and then focusing on the infant, we weigh the baby, developmental screenings like she mentioned, and then we do lots and lots of education and referral to resources that we're aware of. We have to dig really deep sometimes to find those, but that's what these guys do a lot of in linkage to other services. And then, of course, going back to what Chris said, is we always refer to their pediatrician, their OB provider, and if they don't have one of those, then we start that search to try to get them connected with the care that they need. And so our team, we just hired our last staff member about 2 months ago, so we're complete now. We were pretty selective. It was important to me to find people that were a match for the home visiting program, because that's not everybody can go into the homes. And so we matched those with the experience that you see there. So all of these categories, we have somebody who has that experience on our staff. Labor and delivery, home visiting experience, a lot of those individuals have those. NICU, nursery, public health, and then we have some mental health folks as well. And then these are our LPNs, and we are extremely blessed with these guys, one with extensive labor and delivery experience, one with home visiting, mental health. And so they basically, their visit looks a lot like the RN. The RN assists on that visit if needed. A lot of times the RN does the intake, that first visit with them, just to evaluate and make sure their medical needs and assessment are where we need them to be in case the RN needed to do that visit. But basically all those same components, they do the exact same thing as well. And these are the stars of the shows that doesn't necessarily want to talk. You good?
I'm a community health worker. I also come from a health department in Bullitt County. I worked there for 2 years, learned a lot about the programs and services that they provide, which has been really essential, especially when communicating with the patients in their homes, telling of the services they offer there. Most of the time they don't have any income or anything to help them out, but because I'm from a health department, I can always refer them back there to receive services. While I'm at the home, I always report any findings, any concerns with the nurse assigned to that patient. I also schedule visits and do referrals. At the homes, we do case management, car seat education, presumptive Medicaid. I interpret, I'm the only bilingual one in our group. And we also help with supportive services, education, and we educate a lot. It's not just car seat, it's co-sleeping and all that stuff, safe sleep. We do infant care and feeding resources and provide supplies if available. Like if the patient doesn't have a breast pump, we try to find one, give them one, and we help them with it. Holly wanted me to share a story just recently, probably a few months ago. Me and one of our nurses went to do an initial visit to a patient, non-English speaker, Spanish speaking, never received prenatal care. She's young. I think I said she's like 17, I think. We went to the home. We did everything we needed to do. Started telling us that she was having pains like the night before. She just kept going about the pain, and it sounded like she was in labor. And she's never received prenatal care, so we didn't know how far along she was. We were just unsure. And when we did the calculations, it was like 8 months. So we're like, this might be a premature baby. We don't know what's going on. So we advised her that we could call the ambulance to pick her up, take her to the hospital. She declined at first and said that she was going to wait for her mom, who was going to get home at 3 o'clock in the afternoon. They don't have any car. The mom rides with somebody to work. But we were pretty sure that she was in labor. So we convinced her, educated her about the risk of her having the baby at home, especially with no prenatal care. So she finally said yes, and we called later on to check on her. She was 7 centimeters dilated when she was picked up with the ambulance, and she was bulging. She probably had the baby like 20, 30 minutes after she got to the hospital. So if she would have been home all alone, we don't know what would have happened to her. So I think that's one of the things that I think is really, really awesome that we did for that patient. Sorry, I get nervous.
Good job, good job. And oftentimes there are stories like that every day, and so they're huge at building that relationship, and she has the benefit of speaking Spanish, and culturally she knew to identify that she was probably in more pain than we may have picked up on, and was able to encourage her and build that trust, even in a 30-minute window to go to the hospital. So we are seeing a lot of that population want to have home births, and we're totally discouraging that and because they're doing it by themselves. So that's a good thing that we can educate on. Y'all can tell my age. I'm not technologically advanced here. Okay. Yes, sir.
What made you go visit that woman that day? And then had you just found out about her? How did that happen?
Well, usually we receive referrals, and when they know it's a Spanish-speaking patient and it's initial visit, especially that young, they always call me and say, hey, can you ride along with me? I have a patient that I need to go see. And that's how we end up going to their home.
So she had gone that long without any kind of referral?
No prenatal, yeah. It's just
good. So that's just a huge part of case management. It's all of it wrapped together. We spend a lot of time scheduling appointments, trying to find resources. Our community health workers go to all kind of community meetings, trying to find resources for us and also promote the program. So we're often rescheduling and scheduling OBGYN appointments, their mental health if they need it, and just referring as needed. And then you can see the referral linkages that we do a lot of food, and I'm sure you guys are not, you know that we have food insecurities here in Georgia, and when you're in the homes you see it. When you open up a cabinet and they have 2 cans of food, it's real. It's not just something we see in other countries. So we see that often. You have to utilize WIC, SNAP, other sources that we can refer them to. So we get to see the good and the bad. We do lots of breastfeeding education. It's a huge part of what we do. Some of us are IBCLC certified. Some of our staff have CLC. So we're able to support those moms in the home setting, and that's a lot different than a hospital setting, because when the baby's going to act up, what? Oh, okay. So an IBCLC is international board certified. So you have to have some biology, and nurses can do that. So I have my IBCLC. One of the community health workers has their CLC, and it's a certified lactation certificate, which means they've had like a week-long class and test. And it is not an easy test to get that. So you have to have some knowledge of how the mechanism of breastfeeding works. How do we get baby latched? Why are they not feeding? Is there other issues going on? So just trying to guide and support them. And a lot of times moms in the home who have lots of babies, sometimes they just need a support person. They don't have anybody. Dad may not be in the picture, and so sometimes we can be that. It's just that simple for them. So we do lots of that. This is probably one of the most important things we do, and also the hardest thing. So the districts and program coordinator were responsible for coming up with an outreach plan, and we've targeted the last 2 years your OB providers. We spent a lot of time in Savannah with the high-risk doctors trying to promote the program, see what their needs are, and get referrals. And also the important side of that is we need referrals because we want to see our most vulnerable population at high risk. But also I don't need to be in a situation where I have a patient at home who I need to get a hold of a doctor. So we do the outreach so that they know us, and I can call and say, hey, Miss Angie's having some problems. What would you like me to do with her today? So it's just a great partnership that we're always going to have in place. So we're working on community service boards, emergency room staff, and then your non-delivering facilities, because they have people just show up to deliver and they're not prepared for it. So that's our next step this year for our district. And then the challenges, and I laugh because everybody that's stood up here this morning has talked about transportation is probably our most frustrating and hardest issue. And it can be, for us, a multiple reasons. It could be timing of appointments. A lot of times what we see in the homes with the mom is, okay, I think she's tending to have high blood pressure or whatever's going on with her. I really need her to be seen today or tomorrow, and the doctor wants her to be seen, but time constraints with our transportation, they want you to be 3 days. And so I need her to be seen tomorrow, so you have to have a 3-day. And so we try to figure out creative ways around that. So that's something that, and we find that our patients, they don't always want to ride that, and I understand that, or they have childcare. You can't take the children if they're a stay-at-home mom. What are they going to do with their children? So those are just some issues that we try to work around. And then mental health resources, we know, I don't know if anybody touched on that today, but that is a huge, we had an incident on Monday where, and a lot of times if we're heavily involved with our patients in the home, they're probably going to call us if they're having some thoughts or if they're in a crisis, and they do. We've had several of those recently. Had one on Monday. She didn't call her OB provider, she called her nurse, and that was us, and was having some suicidal thoughts. We didn't really have a lot of options but to send her to the ER. Just limited resources when it comes to that. So that's a challenge for us. And then long distance to providers. I think we decided over half of our counties do not have providers. Over half of our counties are non-deliver, or way more than half don't deliver. So they're having to drive, and particularly if they have to see the high-risk OB or perinatologist. In our district specifically, they're going to Savannah, and that can be anywhere from an hour and a half to 3.5 hour drive. So that's a long day for a patient and her family. And then this is on the patient side. They tend to tell us a lot of times that they have a hard time communicating with their providers, and you have to figure out, is it because they don't understand what the provider's saying? So we need to educate more to try to help with that. Are they leaving a message and not getting a call back from the providers? What is it? Are the providers busy and don't listen in the office? We all know we probably experienced that sometime. So again, we try to dig into that, see what they don't understand, what is the problem, and help with those situations. And then substance abuse is, a whole day topic in itself. And you would think that would not be the case if a mom was told she was pregnant, but that is not what we see. And we're very limited with pregnant moms and postpartum moms that would let a woman keep her child. In 16 counties, we only have one facility and it's very small, and it's actually in Ware County. And they will take a pregnant mom, and she can have her child and bring it back to her. But that's only one facility in 16 counties. And I'm not sure what the bed number is. I would speculate probably 30. So really, there's no resources that I'm aware of for that. So that's a huge issue if you have a mom that is truly trying to get clean in preparation for the birth of her child. What can we do for her? So those are just some challenges that we have, and I'm sure that's across the state that you guys hear about that. I did want to say this story. We have the big stories, and we had an infant a couple of months ago that our nurse went in the home, and I think the governor actually talked about this, but the baby was almost completely dead when the nurse went in there, and that baby, the hospital from Savannah called and said, if you had been 30 minutes later, the baby would have died. So those stories aren't every day, but unfortunately we are seeing it more, that we get those stories of the calls of, I'm thinking about hurting myself. And it's a simple thing. It's that we have the capacity and the ability to build relationships like no other because we're in the home. And that's what I'm passionate about. That's what's important to me. And I think that's the key to this program. And this program, in my opinion, will be the catalyst to changing maternal and infant mortality in the state of Georgia. I'm just extremely passionate about it. I believe in it. I think it works. I think it will work. Of course, we're always going to have some kinks we need to work out. That's just with anything. But we had a mom come by on Monday. She came out of the office, and she's a repeater. So, and I say that jokingly, but I say it in a good way this time. So I had her in her first pregnancy, and she had marijuana. And I say that lightly because we see cocaine, so marijuana is much better than the cocaine. But we got her through that. She got off marijuana, has a successful pregnancy. She's clean, has dropped cigarettes, marijuana, working. Great story. She got pregnant with her second child, major mental health issues. We have overcome that hurdle. She's in therapy, taking medication, doing great, just a super mom. Her second baby was born with no thyroid, which is pretty rare. So we've learned a lot with her, but trying to get her appointments in Atlanta. She takes the baby all the way up there. That baby will be on medication for the rest of its life, but she's doing phenomenal. So she brings us her pregnancy test to our office. She proudly tells us she's pregnant with her third child, and so we were rejoicing with her because she's in a much better place now. But I asked her, I said, tell me what this program, you keep coming back, tell me what it has done for you. And she just paused and she said, it has made me whole again, and now I have y'all. And that may not sound like a bunch, but she feels she came from a trauma childhood, and now she has us as a support system. And she feels like she's a great mom now. And so that may not sound like a win, but it's a win for us and for her. So just, if you didn't learn anything else, I hope you realize we're passionate about what we do in serving moms and babies. And I truly believe they should not be dying in this day and age on our time. Thank you very much. Thank you.
Thank you very much for that very passionate and important. We needed to hear this information. We appreciate what you do and for sharing it with us today.
Thank you.
Thank you very much.
Here's some stories. I think y'all might already have copies.
Our next speaker is Babies Can't Wait and Georgia Early Education Alliance. We appreciate y'all being here. If you'd introduce yourself.
Yes, of course. Madam Chair and members of the committee, thank you for welcoming us to beautiful Dublin. Chairman Hatchett mentioned supporting the local economy. If I might recommend Rosie's Ice Cream downtown. I'm a little biased because my daughter is named Rosie, but I think it's some of the best ice cream in the state. So if you've got time after this, head over to Rosie's Ice Cream. I also want to thank y'all for the opportunity for bringing us together to learn about the important work of the Department of Public Health. It's truly an honor to be here. My name is Callan Wells, and I'm the Senior Health Policy Manager with GEARS, the Georgia Early Education Alliance for Ready Students. GEARS is a policy and research organization dedicated to Georgia's youngest children, birth to 5. These early years are a time of extraordinary growth when children learn and change more rapidly than at any other point in life, laying the foundation for everything that follows. Our team believes in listening to families across the state, learning about their needs and dreams for their young children, and helping to shape policies that advance the well-being of Georgia's youngest and their families. To that end, we are strong supporters of the department's child health programs, including home visiting. But today I'm here to talk about Georgia's early intervention program, Babies Can't Wait. As you heard from DPH leadership in the first meeting, Babies Can't Wait connects families to physical, occupational, and speech language therapies, autism services, special instruction, and service coordination for infants and toddlers from birth to age 3 who qualify because of a disability or developmental delay. Early intervention can be life-changing for children with disabilities, providing the therapies they also need during the crucial early years to grow, thrive, and reach their fullest potential. I also want to point out these services are usually provided in the home, addressing those transportation barriers that we keep hearing about. Babies Can't Wait fulfills Part C of the Federal Individuals with Disability Education Act, or IDEA. It is funded primarily through a federal block grant and supplemented by state funding. Additionally, Medicaid and private insurance reimburse some Babies Can't Wait services. Babies Can't Wait is administered by health departments in every region across the state. At this committee's final meeting, I'll share more details about GEARS' recommendations for supporting Babies Can't Wait and other public health programs that serve young children, such as home visiting. But today, I have the privilege of introducing Ansley Hill, a mother whose child received services from Babies Can't Wait. I want to emphasize that when I introduce her as a mother, I do so with the greatest respect. Parenting is the most important job any of us can undertake. It is parents and caregivers who every day are doing the vital work of shaping the future of our state and our nation. At its heart, Babies Can't Wait is a program that supports parents, equipping them with tools, resources, and hope during what can often be the most uncertain and difficult moments of their lives. The true measure of the program is seen not in data alone, but in the stories of families who experience its impact firsthand. It is in that spirit that I now turn to Ansley. Her perspective as a mother is invaluable, and her story will illustrate more clearly than I ever could what Babies Can't Wait means for families and for Georgia's youngest children.
Well, I guess that's just going to run, so it's okay. Thank you, everyone, for letting me be here. I don't have a lot of really important information. I just really want to tell you my story as a mom. I know you've heard a lot about public funding, a lot about programs, but I want to tell you a little bit about how it feels to be on the receiving end of one of these programs. And Babies Can't Wait absolutely changed our lives. But before I get to that, I want to explain a little bit of who we were and how I ever got to the point of ever even needing Babies Can't Wait. I didn't even know that this even existed. I honestly didn't even know anything about real NICU stay. But a little bit about me. I am from Beaufort, Georgia. Sorry, it's been a long day. I live in a little area called Duncan's Corners, so it's where Flowery Branch, Brazelton, Houston, Decula, and Beaufort all meet, so I'm kind of close to everything. I actually grew up in Flowery Branch, Georgia. Went to West Hall, played basketball. We went to state. We didn't win, but we're still upset about it. After high school, I decided to go away to college and then quickly decided I missed my friends and my family, my mom especially, and I came back home. I would quickly meet my husband, Scott. We fell in love fast and got married, built a house, started just planning our life. We still live in this area. He works on a marina in Flowery Branch, and I work in real estate. So we're kind of boring, but we're really entwined with all of our friends and family, and we love our area. After about 10 years of trying to have a baby, start our family, we finally knew that we had to do IVF. IVF was incredibly financially and emotionally exhausting. It's one of the worst things we've ever been through. And on our final attempt, the very last-ditch effort, we finally got a positive pregnancy test after never having one. I was 35 years old. On our first ultrasound, which we were very excited about, we were shocked to find out that there were 3 little heartbeats in there. So very excited, but really terrified about what that meant. We were scared. We were very scared, but we thought, okay, well, we're in our 30s now. Let's just get it all over with in one fell swoop. And, you know, I don't know if y'all can tell, I'm kind of a bigger girl, so I thought I'll be able to handle this no problem. I can carry 3 babies, not a big deal. One day while I was shopping in Publix, my water broke. I was 19 weeks along. I was rushed to the hospital. When we got to the hospital, we learned that at 19 weeks, there's nothing you can do. There's no life-saving measures. The babies are just too small. And on top of the fact that I was 19 weeks along, I had 3 in there. My daughter, Etta Jane, was born right then. We had her for 3 hours. She looked just like me. She had really long legs. I was convinced she was going to be a dancer or a soccer player with the way she was kicking in my stomach. But she was beautiful. I would end up not going into labor with my other 2. So they stayed put, and so did I, on bed rest for 6 weeks. Lots of Netflix and books, and learned how to knit during that fun time. What happened at 25 weeks was I had an infection that was left over from having the baby before, and it would cause my water to break with the other 2. Carolyn came first. She was very in a hurry. She came on out. We knew that she had a heart condition. We'd figured that out from being in the hospital. So she was born and was immediately rushed to another hospital for surgery. The surgery was just a last-ditch effort to try to keep her alive long enough to make it to where she was big enough to be able to have the surgery that she needed that would correct her heart issue. My son, who is still stubborn to this day, was breech and was not ready to come out, so I was rushed into an emergency C-section with him. I can assure you he is still that stubborn to this day. Both of the babies were born 2 pounds. They were immediately put in the intensive care unit, the NICU. They were basically being kept alive. One morning, 10 days after they were born, we got a call. We had to rush up to the NICU. And they said that Carolyn, our daughter, she'd really struggled through the night. And even though they had done the surgery to help her heart to try to put enough oxygen in her body to live, it just wasn't working and she just wasn't getting enough oxygen. And we had some pretty tough decisions to make. What's hard when you're in something like that is, for me, being raised Christian with Christian faith, you're kind of always taught, just put it all in God's hands and he'll lead the way for you. And for us, we were standing in front of a doctor saying, make a decision right now. And that was really, really hard to reconcile, what we thought would happen to the decision we were now being left to make. We ultimately decided that we didn't want her to be in pain. I had a doctor kind of level with me and tell me a little bit about what her life would look like. And we didn't want that for her. So we made the decision to let her go peacefully too. She passed in my husband and I's arms. She also looked like me. It was crazy. It kind of shocked me. It was like looking at a mirror. My son Roland is all dad, even to this day. The funny thing was, on that day when she passed away, it was almost like Roland knew that his sister had passed. It was almost like his little heart was broken too, because he started going downhill. We were like, at that point, how do you handle anymore? But we believed that we were losing him too, and what we ended up finding out was that he had a perforated bowel. And at that time, they said, we need to transfer him to Scottish Rite. And, on top of this perforated bowel, he's going to need a lot more surgeries, monitoring, a lot of, we ended up treating him for brain bleeds and hydrocephalus and lots of prematurity complications. We knew he was going to have vision and hearing loss on top of developmental delays. We would spend months in the hospital. That time was really tough. Not only are you living with grief and loss and you're stressed because you don't know if he's going to make it, you're really, it's just trauma, and it's constant bad news, and it's up and down, and it was one of the toughest things we'd ever been through. The thing that we found out that was really tough during this, and this is really what I want to emphasize, especially since we came from such a huge community with lots of support. Trauma kind of ripples through, and it affects everyone. Family fought each other. We had friends who were our best friends, but they thought they were in the way, so they just didn't show up. We had family members who did that. I know you don't need us right now, and so no one was there. And what ended up happening was we were incredibly alone, we were incredibly isolated, and we were losing faith. As much as I hate to say it, in people, I lost faith in myself, and one that still kind of hurts me to admit to this day is I lost my faith in God back then. One day in the NICU, a social worker came up to me. I think she gave me a couple of weeks to get through and try to get into a normal routine, because it was every day in the hospital we were there. She sat me down and she said, I want to tell you about these programs that are out there. There's something called SSI, Social Security Income. And I was like, I don't need that, I have a job, I'm okay. And then she said, well, there's Medicaid. And I said, I've got this job and I have insurance, so I don't need that. And she said, well, let me tell you about Babies Can't Wait. It's an important program that will help you and start working with you. And I think at the time, I just thought, I don't have time to hear any of this. I just have to focus on, this baby right now. And, when you're in the hospital, it's like drinking water from a fire hose. There's so much information that's coming at you. But what cracks me up even to this day is that sweet social worker knew so much more than I knew, and she knew that I had no idea what my life was going to look like. And she also knew that maybe you have this job right now, but your son, your child, and taking care of that child may not mean you get to keep that job. And it also means that if you don't have that job, you don't have that insurance for him. And she was right. We finally got to take him home after 3 months. The good thing about that amazing social worker is when she sat me down and gave me all this information, she said, here's the number you need to call. Here's the information that you need. I've already printed out your medical information. All you have to do is just make the call because it's a long process. So just start it, even if you don't need it, even if you don't need Medicaid, even if you don't need Babies Can't Wait, just start it. And I'm happy that she did because it was a long process. But after we got home, which is something you think you'd be so excited about when you finally get to go home and take your baby home. It was really kind of devastating. It was lonely when we left the distraction of the hospital and the adrenaline of everything that was kind of going on. You really are left alone with what your life is going to look like. You're left alone with the reality of the situation of, wow, he's really little and we don't know what his life is going to look like and I don't know what to do. Talking back about my community that I had, and I still have a really strong community, but none of them knew what this looked like. No one knew. We had no one in our group that had a special needs child or even had longer NICU stays than a couple of days. It always makes me laugh when someone says, yes, my son was in the NICU for 3 days for a breathing. And I'm like, you don't know nothing. This is nothing like what we went through, But thank you for, trying to identify with me. I get it. But we weren't home a week. And Babies Can't Wait called me and they said, hey, we'd like to come to your house and do this evaluation. And I said, okay, you're going to come to my house? She's like, yep. We'll come to you and let's just go through everything. I'll tell you all about the program because if I'm being honest, I didn't remember what they said to me at the time about what Babies Can't Wait was. And so I couldn't say no. She was coming to me. I probably needed someone to come and visit me because I was stuck at home. And I needed an excuse to get out of my pajamas and I probably needed an excuse to wash my hair at that point. So she showed up. Her name was Dulcie. She met with my husband and I. She sat with us for 2 hours. And she listened to everything that we had gone through. She validated our experience, which was huge to us. She told us what Babies Can't Wait was and what we can do and what our son was really going to need. And the quicker we can start working with him, the better. The first thing that she wanted to do was let's get these therapies ordered. We think he needs everything, and let's start working immediately on him. And I thought, this is more people coming into my home, and I'm going to have to get out of pajamas even more, but I guess I'll do it for him. The best thing that she did when she came to our house and walked us through all of this, we were so lost, my husband and I were, after everything that we had been through, and because we had no idea how to raise a child with special needs, she gave us a plan, and she gave us a little bit of a future, and this is what you need to do, because at that time, I just needed someone to tell me what to do, how to put the, one foot in front of the other. I couldn't even think about the future. I just needed to know what I need to do now. Roland would receive occupational therapy, speech therapy, physical therapy every week. We got connected with Georgia Pines, and you'll see her in just a minute. Her name was Millie, and she would come and work with Roland for his vision needs, and there's a picture there of him looking at this white light-up vision board. He loved it. Still loves things that are light and make a lot of noise. We were connected with Georgia Sensory Project, which helped us with education and school transition and any needs we needed there, which I still stay in touch with them a lot. Through the process, through Babies Can't Wait, we absolutely began to shift from grief to hope and meeting other family members and meeting other people in the community who are family members or have children with special needs, and really were able to see what it looks like, and it wasn't as devastating as we thought. The thing with Babies Can't Wait that I really want to talk about is it wasn't just the therapy that they provided for us. They helped us in so many other ways. At 1 year old, Roland, Georgia Pines right there. At 1 year old, Roland started having seizures. Seizures are not at all what I thought that it was. You know, everything I knew about it was what you see on TV where, you know, this huge grand mal seizure, and that's not what he had. It was a little tick, just a little something we noticed. And you know, his babies can't wait. Physical therapist came in one day, Katie, and I said, do you see this? Does this look right? And she said, no, I don't think that's right at all. And we watched it and we videotaped it. She's like, I think you need to do something about it. And it was something that we probably would have dismissed for a lot longer, but she helped us, you know, realize something was really going on here. And he would be diagnosed with infantile spasms. Those were due to the brain bleeds that he had. So we were able to identify exactly which part of his brain was causing the seizures. And we were able to do a hemispherectomy and cut that out. And he has not had, knock on wood, not had one seizure yet. And that was 7 years ago. Not a seizure since. When we knew that Roland, I mean, he's standing in a lot of these pictures, and if you hold his hands, he will stand, but he has to have a wheelchair. So when we knew it was time to get a different way, a different mode of transportation, especially since he would be going into public school, she connected us with the company to get us fitted for a wheelchair, and they came to our home to fit him, help us pick out what we need, and then helped us get it worked out through our insurance, which is amazing. And then when it was time for, when it was COVID, they actually, right before everything shut down, his occupational therapist and physical therapist ran over to the house, didn't come in, but sat on the front porch, some tools for therapy, and they continued our sessions over Zoom with us, so he did not miss any of his therapy. I just always thought that was so thoughtful they did that. And then when he finally was ready to go into school, our representative from Babies Can't Wait, Jamie, actually went and met with us with the school board and walked us through what that whole process was going to look like and answered questions for us about how it was going to be to have a child with special needs in school, which was something, again, I had no experience with. The thing I want to say ultimately, and this is what worries me with everything that I'm hearing, you know, with funding cuts. I know y'all are beat up with questions about funding, but I worry about people losing access to programs like Babies Can't Wait. Because for me, I'm educated. I worked in compliance for 18 years at this point. I have no other children. I have a loving husband who's an amazing father to my son. I have strong family support. I mean, my aunt's freezing over there right now, but she's here. I have a roof over my head. I have a car that drives. I speak the language. And going through this was still impossible. It's the hardest thing I've ever done, and it's still really, really hard. It doesn't end. I wish Babies Can't Wait continued on. It'd be great. But I worry about it, and I hope that it's as important to y'all as it is to us that Babies Can't Wait continues and that it continues to help families, because if I had all the opportunity and all the help and all the resources in the world and it's still impossible, I can't imagine how hard it is for other families. And yeah, that's it.
Representative Osteen, I think you have a question.
Bravo. Have you spoken to people before about this publicly?
So about a year after my son was born, they wanted me to come back and work with parents. The lady at the NICU at Scottish Rite asked me to come in and just be a part of a support group, and it's kind of turned into me actually talking and working with parents who are going through this, mainly because when I went through it, you know, again, unless you've gone through it, you don't truly understand how it feels, you know? And for me, I kept pushing it away. And if I just reached out a little and talked to someone, so I go back every other month and say, please just ask any questions, just know you're going to get through this, and just try to let people know that, you know, hey, you're not the only one who's been through this. So I speak a little bit more than I ever thought I would. I never wanted this life for me, but I'm happy if I can at least raise awareness for what I went through.
Well, I'm grateful you came today. I learned a lot, and Babies Can't Wait stops, is it 7 or 8 years old? When is
3.
3, okay. So, you know, your son is 8, right? So somebody's still helping you from Babies Can't Wait?
So I was obsessed with these ladies here, and I followed them to their private health care, their private therapy clinic. So I still see a lot of these ladies and still work with them in their private
That's
therapy
where I
clinic.
was kind of confused, because I was thinking it was 3, but then I knew he was 8, so I thought, well, maybe I'm mistaken.
Yeah, he's a big boy now.
You've been through a lot, and I can't even imagine. I cannot even. I went through infertility. I know what that's like, but any of the other things that you've described, I can't imagine. And I'm so grateful that our state has this program. And I think we've learned through a lot of our meetings, and especially today, how imperative it is that we continue to value life and that we protect it, and that we do everything we can. Like Holly said, you know, in 2025, we should not have the infant maternal death rates that we do. And I'm all for whatever we can do. Thank you for coming today. I really appreciate it.
Thank you for having me. I appreciate it. Thank you.
I would like to thank you also on behalf of the committee. It was very brave of you, and we're very grateful that you were able to share this with us. And it's just opening, I think, everyone's eyes to what public health is. It's not a one thing in a box. It's many things. And again, we're very grateful for you coming today. Thank you very much. And as I address everyone, I will tell you this has been a very successful meeting. I think we've had a lot of great information, and we appreciate every one of you that have come and been able to share with us today. And we look forward to our climax from these meetings. So we have one more to go, but thank you very much, and we are adjourned.